Cool. Hello, everyone. We've got some PEDS revision questions for you. Just a side note, a little plug. Our lovely academic coordinator, Elise, who's here, has made a bunch of videos on you, quite a few videos on YouTube as well. We've got a YouTube channel, like and subscribe. Um, and yeah, and we've also got, we can maybe send the link out after, but on the Muppets academic drive as well, there's a bunch of revision questions, past exams, summary sheets, whatever you need. All the buzzwords like the Ankies, because there's a lot of buzzwords in PEDS. Um, and yeah, and also come apply to join our committee next year. Um, it's a really fun one, so apply.
Does anyone want to share their thinking for this question? Anyone at all? No wrong answers. I mean, there sort of are, but it is a judgment-free zone if anyone wants to. Yeah, go for it.
The main kind of management is giving them oxygen because the baby oxygen saturation is low, and then NG feeding because when they eat they don't breathe and then that worsens their oxygen.
Yeah, awesome. So as you Awesome, thank you. As you said, yeah, would be admitting them for supportive care. And that's mainly because, as you said, yeah, the mainstay of treatment for bronchiolitis is just supportive care, maintaining their oxygen sats as appropriate, and because babies are obligate nasal breathers, they may need some nasogastric hydration. If I guess you do a clinical assessment, they seem to be clinically dehydrated. Yeah, okay, we'll move on to the next one then.
Wait, look. So, cool. Does anyone want to share their answer or their thoughts for this one? No. Um, this it's a tricky one. Um, yeah, so the answer is C, severe. Um, yeah, this question's kind of testing how well you know the RCH guidelines and I guess how they classify different um, severity of asthma. What makes this severe? If we go back to the question as well, I guess what you can kind of look at to determine the severity of asthma, um, so the saturations, all the OBS, so the respirate and the saturations, and then also some of the clinical signs here too. So in this one, he's still although he's speaking in short phrases, he's still speaking. Whereas, if it was a life-threatening or impending respiratory arrest, wouldn't be able to speak at all. Auscultation's also a good one. So, there's still a wheeze present and good air entry. Whereas, in a life-threatening kind of event, there wouldn't be any at all, or very, very little. Yeah, other things that you would want to look out for, this would have the potential to progress to a life-threatening one, but what are some of the features of a life-threatening episode of asthma that aren't present here? Just shout them out. Yep, silent chest. Yep, yep. And also like cyanosis as well is another one. But yeah, so RCH have some good, and you can kind of see here some of the different classifications. Um, Moderate, well, some of the, um, I guess clinically moderate, they'd still be able to kind of speak in full sentences. They'd be quite short of breath. Um, yeah, also the saturations in this one and the respirate are pretty not good. So 93% as opposed to moderate would be probably a little bit higher. But the main one is that kind of speaking in short sentences. Yep.
Okay, moving on to a cardio question now. Okay, does anyone have any particular thoughts for this question? What was that, sorry? Was that D? B. B? Yeah, perfect. And do you want to explain your thinking for that one? Yeah, no, that is definitely the right answer here. And does anyone want to call out, like with some of the other, I guess, lesions, what would you expect to see on chest X-ray? Or what murmur would you expect to see instead? So if we thought about A for TOF, yep, perfect. And then obviously we've got a VSD here. And with this one, because there's a soft murmur, do we think that it is more likely to be a large or a small VSD? Yeah, great. Okay, and then with TGA, what would we expect? Yep, perfect. Egg on a string appearance on chest X-ray. And then with an ASD, what sort of murmur may we hear? Yep, perfect. And then for PDA, what would we expect here? Yep, perfect. Okay, awesome. That's just all what we spoke about. But you guys will have these slides, so. Okay. Yeah, okay.
Cool. Does anyone have any thoughts on this one? Want to share their answer? It's a tricky one. We're just going to fact check. But yes, C is the right answer. What's your thoughts behind, what's your thought process behind C? Yeah, yeah, spot on. So just kind of going through each of the answers. So she's given that she has mild mitral regurg, it gives a good insight into, I guess, the things that you want to look at are the age of the patient. So she's 14, she's quite young. The history of rheumatic fever, whether it's, she's had it once or multiple times in the past. And then as well, some of those like long-term complications. So mild mitral regurg means that, it's progressed to a pretty decent degree. So A, no treatment is necessary. That's wrong because there's already, been quite a degree of damage. D, going to D, the valve replacement, given that it's mild mitral regurg, is also pretty young. That's that would be something that you'd consider in a much more severe case. And E, a corticosteroid wouldn't. I guess if you're thinking like prevention of infection, that kind of does the opposite. So that kind of leaves B and C. So we're just fact checking what you said from before. Okay, so the time frame depends on the level of cardiac involvement. So because she's had, so if there's no cardiac involvement, it would be 5 years. But given that she has mild mitral regurgitation, it's 10 years. Yeah. So I guess what we were trying to see with this question is first determining severity, and then also determining method of administration. So with the Ben pen, it is given IM, whether it's cardiac involvement or not cardiac involvement, that's how it's given. But yeah, so that's why it's 10 years as opposed to 5. But if she didn't have that mild mitral regurg and still had that history, it would be 5 years instead.
Okay, question 5. Any thoughts for question 5? B? Yep. And would you like to explain why I picked B? Mm-hmm. Yeah, great. Okay, so it was explained that this is TGA. So then, hence, we'll need to give prostaglandin to keep the PDA open, and then arrange surgical correction after that. So yeah, as it says here, usually the surgical correction is within the first week of life, but that's not the immediate priority. You want to keep that PDA open to allow the flow of some of the oxygenated blood. And then after you've achieved that and you've stabilized the baby, then you would think about surgical correction.
Long question. All right. Does anyone want to have a go at this one? C? Yeah. And why C? Yeah. So I was just explaining to the people on Zoom as well, but we've got an answer of C, Rolandic epilepsy, because it's a focal seizure, and carbamazepine helps with focal seizures. So yeah, that's a really good like thought process kind of approach to this question in terms of well, first of all, determining, what kind of seizure is this? So it's, a focal seizure. There's no tonic clonic movements. So the reason why A and E are incorrect is because those would be more kind of tonic clonic seizures. So you can rule them out based on, the type of seizure that Benji's having in this case. And then why would it not be B or D? Like what makes you lean more towards C in this case? So B and D are kind of much more um, severe, types of epilepsy where typically they'll present a bit earlier as well. So, present in early childhood or even infancy. And both Lennox-Gastaut and West syndrome are also associated with a lot of other issues such as, developmental delay, learning difficulties, and even developmental regression. So like losing skills that have been originally acquired. So the prognosis for Rolandic epilepsy is quite good. Like you mentioned, the treatment with carbamazepine, and typically as well, after like around the teenage years, these seizures kind of stop themselves, and don't carry on into adulthood.
Okay, question 7. Sorry for all the really wordy questions at this time of the morning on a Saturday. Okay, any thoughts for this question here? E? And would you like to explain how you came to E? Yep, great. So it was identified that this is, wait, do you want to say what the condition is? Yep, great. So this is status epilepticus. And we know that because I guess status epilepticus is prolonged seizures beyond 5 minutes, typically. So we can see here we've got this young girl with epilepsy. They've called an ambulance because it's gone over 5 minutes. So after 5 minutes, we'd give the first. So there is a really good flow chart on the RCH guidelines, but after 5 minutes, we'd give that first lot of midazolam. And usually if it's at home, like she's got known epilepsy, so she probably has a midazolam action plan. And in that case, she's going to be given probably buccal or sublingual midazolam by her parents. And then because after the 5 minutes, she's still seizing, that's when we need the second line agent, which is typically IV midazolam. And then if they are still seizing after that, then phenytoin is the next agent. Could also be levetiracetam, but the first two need to be midazolam. That's why it's E.
Does anyone want to have a go at this one? Feel free to just shout an answer out. D? Where's D? Sorry, I missed who said it. Don't hide. What's your thought process behind D? Yeah. Okay. Any other answers in the room? A. And why A as opposed to D? Yeah. No, really good. So for those on Zoom, we had an answer of D, because there's not a heap of swelling. Oh, we had both answers. We had an answer of D, but we also had an answer of A. So a bit of variety in the room. So yeah, so the answer is A. So really good explanation. So the reason why it's not D or E is because, like you said, that would be more likely to affect the joints such as, the knee, the hip, where in this case it's more localized to the thigh itself rather than a joint. C, I mean, in terms of C, there's no other kind of signs or symptoms to point to leukemia. And B, septic arthritis typically kids with septic arthritis, they won't be able to weight bear at all. Whereas this kid is, limping but still able to weight bear. But yeah, so the answer is A. It's also important to think about the part of the body that's affected too. So this kid in this case is having some pain and swelling in his thigh, and that's a pretty common spot that osteomyelitis affects. But I suppose the main kind of take-home point and what we wanted to kind of ring in with this question is that osteomyelitis can be quite non-specific in kids where, there may not be a fever, there may only be, minimal swelling. It's not a super clear picture as it would be, in adults, for example. So yeah, that's kind of the point that we were trying to ring home. And yeah, so there was an elevated CRP in this case, but an MRI is the best kind of tool to diagnose it. But yeah.
Question 9. Do we have any thoughts here, this question? Yeah. Okay, we had a C. And would you like to explain how you came to C?
It's pretty difficult to get a spiral fracture. Put it on the screen.
Yeah. Yeah.
Sort of back and chest.
Yeah, no, really good. So the explanation there was there's a spiral fracture, which is probably quite difficult unless the child has, I guess, some sort of bony pathology, and also the bruises as well. So I guess with NAI, you're really looking at, first of all, the story given by the parent or the caregiver, and then you're looking at the pattern of injury and you're thinking, does that actually align? Particularly with bruises, I guess you expect bruises to be on, I guess, thanks, on parts of the child's body that make sense. If they're on their elbows or bony surfaces, but less so on areas like the back and chest, as it says there, they're soft tissue areas. Yeah, so I guess there were quite a few red flags in this picture here.
And the mechanism of injury doesn't match the story at all. His uncle is lying. Question 10. All right, does anyone want to have a go at this one? It's a good question. I don't think baby formula has gluten in it. Don't think so. Fact check. Baby formula does not have gluten. Cool. Any answers for this one? And what's your reasoning behind that? You guys got a buzzword document up there with you? That's all the answers are coming from this table. It's a bit suspicious. Okay. Sorry, go on. Yeah, so spot on. So I guess the key things pointing to that. So the itchy rash on his cheeks and trunk. So in terms of why the other answers are incorrect as well, reflux, well, it wouldn't be reflux disease. It would just be reflux. But you wouldn't get that itchy rash. You might get the poor weight gain, but not the itchy rash. Celiac disease typically would not present this early. Presents, in earlier childhood, and there's no gluten in formula, as we just found out. Cystic fibrosis as well. That would often be picked up on the newborn pinprick screening, but if it was missed for whatever reason, you would also get like potential, infections and stuff too. It would be a bit more kind of serious. And lactose intolerance is very rare in babies. And again, it's the kind of erythematous itchy rash, which is quite typical of cow's milk protein allergy.
Moving along to question 11. This is a nice one. Thanks, Melly. Okay, do we have any answers here for question 11? What was that, sorry? And would you like to explain your thinking for A? Maybe I'll ask to see if there's any other answers in the room first, but then I'd love to hear your explanation for how you remember it as well. Do we have any other answers in the room as well? C. And why do we have C as an answer as well? Yep. 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 Okay. Yep. So we had C as an answer because they are the antibody markers that you test in serum. And they're the initial, I guess, sort of test that you perform, and then small bowel biopsy ends up being the definitive test. And that A, they're the gene typing that you might do for family members. Could I hear your way of remembering it anyway? Because that could still be really useful.
Ate too much Dairy Queen, which has.
Oh. Gotcha. Okay. But hey, now still cool way of remembering it. I like that. Thank you. Thanks for sharing. But yeah, so with the gene typing, as it says here, it's not incredibly specific for celiac because only about 1 in 30 people have it. Yeah, and then I guess the stool MCS. If we go back to the question, I mean, this is chronic diarrhea at this point. If it was acute and persistent and you'd maybe ruled out celiac, then you might go on to do a stool MCS if you're thinking it's some sort of infective picture. Iron's obviously quite specific, and fecal calpro is used mainly for IBD as like an initial marker, a marker of the level of inflammation. So that's not going to be helpful in this particular picture.
Cool. Anyone want to have a go at this one? Yep.
Your voice, like dry, but still interesting. So I would say that the husband is start with some like vector management, the whole rehydration.
Yeah. So for those on Zoom, we got an answer of B. He's not super duper dehydrated, but also kind of that stepwise approach. So in terms of dehydration, RCH have got some really good guidelines to look to assess the severity. I guess the key pillar of management is starting small and then going from there. So oral rehydration, so gastrolyte, hydrolyte is what you go to first. And then if that's still not working, you go to NGT before you would try IV rehydration. So IV is typically only given, in very severe cases of dehydration, but also, if a kid's in shock for whatever reason, whether it be like an infection or something else. So oral rehydration is always the first thing. And so just going through the question again, IV fluids immediately would be overstepping. His mucous membranes are slightly dry, but again, you look at it, he's alert, interactive. He's only had a 2-day history of watery diarrhea and vomiting. So, he's still got some reserve there. So that, and also you would start other things before IV fluids anyway. NGT, again, you always want to start oral, assess and reassess. It's constantly reassessing. Antibiotics aren't going to do anything because it's very likely a viral illness, and withhold fluids until vomiting stops. Probably won't help very much. Cool. But yeah, RCH have got really good guidelines for dehydration. Question 13.
Okay, this one is quite tough. All right, any thoughts for this one? We had a B, and would you like to tell us why it's not why it couldn't be a pituitary adenoma? Sorry, why it could not be. Mm-hmm.
it's not.
Okay, great. So we had an answer that I guess essentially this is a primary hypothyroid picture based on the TFTs because we have a high TSH with a low T4, and that if we had a pituitary adenoma, because this is because in this picture the impairment is at the level of the thyroid, whereas with the pituitary adenoma, we would then expect the T4 to be high. And with all of the other conditions, I guess they're all at the level of the thyroid, with either thyroid tissue being attacked or I guess atrophic. And I guess the key with this question is that you don't necessarily have to know what the other options are, but just understand that because it is primary hypothyroid picture, then it couldn't be pituitary adenoma because that's at the level of the pituitary gland.
All right. Does anyone want to have a go at this one? Tricky one. I'm hearing some murmurs of A or B. Does anyone want to be brave and shout one of them out? B? Why? What makes? Well, why? Which ones are you between? A and B. Yeah, fair enough. Why? Why do you lean towards B over A? Yeah. Um, do we have any other answers? That's not a nice one to hear, right? Yeah, A. Um, so first of all, what's kind of clinical picture is going on here? What's happening here? Yeah, spot on. So really tricky question. So the SPIDER acronym's a really good way to approach DKA. And the reason it's A instead of B, because they're both pretty reasonable answers, is the priority right now is the dehydration. So he's, got dry mucous membranes, delayed central cat refill, obviously going through DKA. But, there's also the 12-hour history of vomiting. So yeah, the first step with that SPIDER acronym is the bolus of sodium chloride. So yeah, it's correcting that dehydration first before moving on to the management of the sugars. So yeah, so after that bolus has been given, they'd reassess and then give the potassium. And then if you keep going along the SPIDER mnemonic, because it's a really good one, insulin, dextrose. I think it's E. Is E evaluate again? Oh, electrolytes. Thank you. And then R is reassess. But yeah, so I guess what this question wants is the initial management step, which would always be starting with the bolus of sodium chloride before moving on to the next steps. This is a big YAP thing, but RCH guidelines are really good. But yeah, correct dehydration first before playing with the electrolytes is the main point in this one.
Question 15.
Yeah. Back check time. Sorry, we'll go back quickly. No, we'll keep it up because it's good you're learning. Plus minus potassium. Correct dehydration. Great. You're right. Sorry. So just to go back, going back to this question. So because the potassium, so in terms of giving the potassium in this case, given that so if the serum potassium is greater than 5.5, you would not use potassium containing fluids until that's improved, or if the child's anuric, where in this case we're not sure. So yes, so you can use fluid containing 40 millimoles per liter of potassium chloride in this case. Good pickup on that, because that's, yeah.
I guess as well in that case, it'd be important to make sure that there was like a urinary catheter in, because if he was anuric, then I guess you wouldn't do the potassium, but no, that's a really good pickup. I guess we'll probably go with potassium based on the guidelines, but I guess you also need to factor in if he's producing urine, which I guess we didn't provide in the question. So probably not a great question on our end. Yeah.
Is it fine? Givable and then put an IV in for like maintenance for this kind of fluid?
Give a
Or do you
bolus
think-
of,
Let's scan.
I think you'd end up giving ongoing maintenance fluids, but this is to correct the initial severe dehydration, giving him this initial bolus because he's in shock, I guess, in a way as well. If that makes sense. Okay, we'll go to question 15 now. Okay, for this particular question here, question 15, do we have any answers? Any thoughts at all for question 15? What was that? Sorry. Yep. We had a B. And why is it B? Mm-hmm. Yep, no, great. So the explanation was this is a 3-week-old baby. So I guess they're still a neonate. I mean, I guess we don't know if they were premature, if they were born at term. But just because we're given that they're 3 weeks old, we would be concerned about a serious bacterial infection, and hence we would want to refer this child on so they can get the full septic workup. I guess as well said, some of the answers said oral antibiotics, but in a 3-week-old, I don't think I ever saw on placement last year the 3-week-old receiving oral antibiotics. I feel like they always had IV whenever they needed antibiotics. Yeah, and as the explanation says here, because a UTI in a neonate is quite unusual, we would eventually probably do a renal ultrasound as well to make sure that there's no anatomical abnormalities there, but that's obviously not the immediate priority.
All right. Anyone want to have a crack at this one? Not someone from this table because they're getting all the answers. B. Yeah. And what's your thought process behind B? Yeah. Do we have any other answers? Pardon? E. Yep. And why E? Yeah. So so yeah, you are right that alarm training is the first kind of line, but given he's only 5, doesn't need it just yet. So from 6 onwards, typically, is when they start. But yeah, the answer is E, so reassure and do nothing. So it's pretty normal at 5 years old to still wet the bed. It's still within the normal range of development. Another important part of this history is looking at other, the daytime kind of symptoms as well. So he's voiding, between 4 to 6 times throughout the day. He's not incontinent throughout the day. He's not constipated either. So those, if you were worried about, a different kind of pathology, you would expect, some daytime, wetting, other things like that. Oh, whoops. So yeah, investigations, again, it's still within the normal, range of development, so no need to do any investigations. Alarm training would be the first line if, let's say, a year later, this still hasn't resolved. Desmopressin is more so for kind of short-term relief, so like school camps and stuff where, you won't have access to, I don't know, the alarm or whatever. So that's kind of for short-term relief for a few days. It shouldn't be used long-term. D, there's no kind of signs of a UTI at all. So yeah, no, E is the correct answer. It's still very normal at this age.
Okay, changing up with some ENT. Alrighty, do we have any thoughts for question 17? I'm hearing a couple of answers over here. Yep. Yep, great. Okay, no worries at all. So we had really good rationale there that this child is less than 6 months old, so we need some form of antibiotics. We had an answer for C. Do we have any other takers? Did I hear mutterings of a B? Yep. Okay, great. Yeah, so the answer here is B. Wait, do you want to go back to the other one? That's a lot of words. Yeah, so in this case, I guess there are some specific criteria for when you go immediately to using antibiotics. One of them being that the child's less than 6 months old. Other criteria are if it's bilateral disease in Aboriginal or Torres Strait Islander children, children who just have one hearing ear and they have acute otitis media in their only hearing ear. If you think that there might be a suppurative complication like mastoiditis, for example. And in terms of the antibiotic choice here, this is like really tough and mean, but does anyone know when you would go for augmentin duo or amoxicillin? I'm not going to try and pronounce the other bit instead of just going for amoxicillin. Yep. I think, yeah, that's on the guideline, isn't it? I'm pretty sure. We had a response said that if they don't improve within 2 days, and apparently as well, if they've also had amoxicillin in the past month. Yeah. And if they have unresponsive acute otitis media.
All right. Anyone want to have a go at this one? Pardon? D? Yeah. Why D? Mm-hmm. Cool. Do we have any other answers? C? Yeah. Yeah. So for those on Zoom, we've got answers of C and D. So I guess the first kind of point of emphasis here is that given that this is a First Nations kid, you would want to start some antibiotics, straight away. So in terms of A and B, that's why it's not A and B. You wouldn't, wait to get the results before you start antibiotics. And again, there is need for some antibiotics here. And what are some of the features of this infection which would make you lean more towards like this is a bacterial infection? Yeah, so the exudates on the tonsils. So that's why it's not B, as opposed to C or C and D. So the two answers that we got. So both of them commence antibiotics, which is what you want. The next part of the question, which is what it's trying to test, is how do we actually get, a diagnosis of a group A strep infection? So a serology would not be able to give us that diagnosis, whereas a throat swab would. So that's why it's C as opposed to D. And what are some kind of risks if you didn't treat this straight away? What are some potential like long-term consequences or risks in this kid? Yeah, rheumatic fever, scarlet fever. Yeah. It's they kind of just like it's pretty safe to say that it's a group A strep infection. Um, like you'd be fine without it, but they just do it anyway. So yeah. Um, yeah. Doesn't really help that much. Oh, that you wouldn't do a throat swab. Um, Not really. I mean, I suppose if there's like a threat to the airway, like an epiglottitis, something like that, you wouldn't do a throat swab, or um, like a parapharyngeal abscess, you wouldn't do a throat swab. Um, yeah, given that it's, this isn't a super severe presentation, it's pretty safe to do a throat swab. But yeah, if you were worried about a more like severe kind of threat to the airway, you wouldn't do it. Also, often in like younger kids as well, you know, if you know it's going to be really tricky to get a throat swab, they might not do it as well. Yeah.
Question 19. I think you did. Get it. All right. What are we thinking for question 19? Any thoughts here? What was that? Sorry. D? Yep. And would you like to explain, Frank, why you thought D? Mm-hmm. Mm-hmm. Great. Okay. So we had an answer of D because, and the giveaway, oh yeah, what condition are we thinking for D? Yeah. So this is likely anaphylaxis. And that's because of the concurrent urticaria and bilateral wheeze. I guess we have a nice little bit of a giveaway in the initial stem that this child has a known peanut allergy. But then we've also been given the red herring that he's had worsening asthma symptoms over the past couple of days. So, sorry. Past couple of days. And look, this could be potentially asthma, and he's just got this urticaria, but obviously we're not going to delay administration of adrenaline. It's not harmful. If you give somebody an EpiPen, it's better just to give it to them and they're not actually experiencing anaphylaxis than to delay giving adrenaline, particularly in somebody with a known peanut allergy as well. Sorry. Because I got this wrong. All right. Anyone want to have a go at this question? It's a bit of a tricky one. All right. We've got an A. We've got a C. Any other answers? B. We've got a B. So we've got a few different answers. It's a tricky one. We can go through, I guess, one by one. So first of all, what is likely to be happening here? Yeah, a febrile seizure is likely. Okay, just going through each of the answers. So A, measuring the temperature itself isn't really gonna change anything. So that's why you wouldn't do that. It's not gonna affect her management. We had an answer of C as well, given antipyretic. If it is a febrile seizure, again, this is all about the priority in her management. And if it is a febrile seizure, that's something that would help, symptomatically down the line, but an antipyretic itself isn't going to stop the actual seizure. And this question is kind of about priority in her management. I am Medaz. When would we give I am Medaz in this case? Yeah, so status epilepticus. So this has just started. So you wouldn't jump to that straight away. And IM penicillin's not really going to do much. So the answer is B. So tricky question. I guess what this question is kind of testing is looking at reversible causes of seizures. So this is a 20-month-old who's having a febrile seizure, most likely triggered by some kind of viral illness. And if you're looking at like the doctor ABCs, she's still, her airway's still intact. So given that, she's safe from an ABC point of view, lots of people say, well, this is ABC, DEFG, ABCs, and then don't ever forget glucose. So that's why it's check her blood sugar level in this case.
So yeah, a lot of answers as well. She's febrile, but it's not a priority to get a temperature. Antipyretics won't help heaps, but yeah. So hypoglycemia is a reversible cause of seizures that you would need to exclude immediately. So this question's kind of looking at, emergency management, your ABC, and then the DEFG.
Moving right along to 21. Okay, does anybody have any ideas for this question? Or even starting off with what people think the diagnosis is in this child? Yep, I heard it somewhere. I'm not too sure. Was it on this? Yeah. What was that?
Measles?
Yep, great. So this is measles. And what sort of spelled that out for you, that it was measles? Yep. So fever, cough, coryza, and conjunctivitis. And we also have the small white spots. What are they? What's that buzzword name? Koplik spots. Yeah, great. Okay. And then because it is measles, what is the management for it? We had a C. Is measles bacterial or viral? Yeah, yeah, it's viral. So it wouldn't be C then, but good thought. Any other takers? What was that? I don't know which table that came from. We had a B. Yeah, great. And do you want to explain your thinking for that? Mm-hmm. Yep, great. So the explanation was that it's viral, so it's going to be self-resolving, and I guess just supportive care in this case. Interestingly, apparently the vitamin A is given if severe or the person's deficient. I didn't know that, so that's interesting. What do we give acyclovir in? Is it anyone know what we might give acyclovir? Oh, yeah, we had a taker for HSV. Yep, that's great. And then in terms of D, that's sort of describing chicken pox. So keeping the child away from school and just giving like calamine lotion just to help them be a bit more comfortable.
There was.
Did you guys open up the blinds? The blinds just open.
They just cut out the whole screen.
I look need to stop.
God,
I think we're good to go.
Yeah, okay.
Sorry about that interruption, guys. Mogig rolled up and they reckon they run the joint.
Wait, do you want me to? Yeah, and so it is. Oh, we're back. No, we're not. Okay, so it is notifiable. Sam, what are you doing? It is notifiable. But IVIG is not required. So that rules out E. Okay, we'll do 2 more questions.
Keep an eye out for measles. There's lots of unvaccinated kitties, especially if you're at the William Anglis Hospital. There's a whole lot of unvaccinated kitties rolling around there.
Our team was.
Did I do this one?
I think this one. This was Lizzie.
All right. Anyone want to have a go at this one? We got a C. Yep. And why C?
Psychobiotics, or you investigate, you probably do a lumbar puncture, but you do it after. Pretty good thing.
Yeah, spot on. So, we got an answer of C. So the priority is to start antibiotics, and then do a lumbar puncture down the line. So yeah, that's absolutely correct. So the priority is, given in the case that it's, a 3-month-old infant, you don't really spend time digging, looking around for, is this meningitis or not? The key is starting antibiotic treatment straight away. So that would involve, hospital admission, IV antis, blood cultures, and then after you've started the antibiotics, that's when you would then move to doing a lumbar puncture, which is the diagnostic agent. So, like going through the answers, A, CT head, again, isn't going to be very helpful in meningitis. D, FBE, those, again, aren't going to really add much to your management or change what you do. We've got a question, yeah? Would you CT before the lumbar puncture? The answer is no. So in this case here, the bulging fontanelle, whilst it's like, it can be like a sign of increased intracranial pressure, you wouldn't, hold on. Just do the lumbar. Wait, what was the question? No, why would you defer the lumbar puncture? Like, because I think he's saying like he's got a bulging fontanelle that's raised ICP, so why do we do lumbar puncture? Because that's a sign of his ICP. Which is fair, but that's just not how I've seen it. That was always just lumbar puncture. That's a good point. Yeah, it's a good point.
We're just checking that that question it was asked about. Because this baby has a bulging fontanelle, why would we not CT first?
Okay. Sorry. So with that, that's a really good question. So a bulging fontanelle can be a sign of increased raised intracranial pressure. In terms of contraindications for a lumbar puncture, so that would include significantly altered consciousness, which this infant doesn't have in this case. She's still crying. Other ones include focal neurological signs, which she doesn't have any, or any signs suggesting a space occupying lesion. So a bulging fontanelle in the absence of other signs of raised ICP is not a contraindication for a lumbar puncture. Cool. No, thanks. That was a good question. Yeah. But yeah, key pillar is this is an emergency. You start antibiotics, worry about everything else after.
Hello, everyone. I hope that you're all feeling good about your exams. We're just going to start off with the first question. I'll just give you about 30 seconds to read the question and answer. Okay, does anyone have an answer for question 1? Yes, someone said C. So for this question, because it's a structural cause that's causing these symptoms, surgical management can be quite effective. Obviously, you take into account patient preferences as well. In terms of why it's not the others, so hysterectomy, while it is definitive management for fibroids, it won't preserve fertility. Diagnostic lap isn't really indicated for this situation because you've kind of already picked them up with the ultrasound. And then, myomectomy because it's symptomatic treatment for fibroids and it preserves fertility. In terms of endometrial ablation, it's pretty unsafe for both the patient and the fetus post endometrial ablation. So they often they'll recommend tubal ligation with that as well. And then TXA, it can reduce bleeding, but it won't remove the fibroid, and so it's not definitive management. Next question. Okay, does anyone have an answer for this one? Yes, a lichen sclerosus. Yes. That's a good question. I'll double check for you. And then I'll get the girls to double check. And then while we move on, I'll get back to you. Okay, so yes, lichen sclerosus. So it often presents with white atrophic plaques in that figure of 8 distribution, common in postmenopausal women as well. So next question. Okay, so they've just checked and you can do a myomectomy for intramural fibroids. Okay, does anyone have an answer for this one? Yes, so I think some people in person answered B, so vulvodynia. Vulvodynia is that chronic vulvular pain without visible pathology, often burning or stinging, and it's exacerbated with touch, such as in this case. Next question. Okay, does anyone have an answer for question 4? Yes, C, so overflow incontinence. So in this scenario, you have the poor stream straining to pass urine and an enlarged bladder, which is consistent with voiding dysfunction, and leaking urine with an enlarged bladder suggests overflow incontinence. Next question. Okay, does anyone have an answer for question 5? Yes, so some people are saying D, pelvic muscle exercises. Yep, so this is a scenario with stress incontinence. So in this scenario, you have lots of risk factors for stress incontinence, such as having a past history of vaginal deliveries, smoking, and then in terms of, so usually you will start with pelvic muscle exercises guided by a specialized physiotherapist. There are surgical options as well, but they usually will like to discuss with the patient and start with conservative options. Question 6. Oh, sorry. Someone just asked regarding the previous question, why would you not, I'll just go back if I can. So why would you not prescribe why is C not the answer? So that is a beta-3 agonist, and it's usually used for urge incontinence, but they often still will start with behavioral measures prior to this. Okay, does anyone have an answer for question 6? Yeah, the McRoberts maneuver, some people are answering C, that's correct. So in this case, the reason that A is wrong is because they often will avoid fundal pressure because it's associated with brachial plexus injury, uterine rupture, and hemorrhage. They use suprapubic pressure, not fundal pressure. And the suprapubic pressure is used alongside McRoberts to help dislodge the shoulder. You should not use excessive traction because it can cause neonatal trauma and brachial plexus injury. McRoberts, this is a shoulder dystocia. McRoberts will increase the functional size of the bony pelvis, and it's an appropriate initial maneuver. Reverse wood screw is an internal maneuver that is used to manage shoulder dystocia, but it's just not the initial step. And that's the same with Rubens too. So it's really helpful to know that HELPER acronym. It's actually in the prompt guidelines as well. So it's good to review that before your exams. Next question. Okay, does anyone have an answer for question 7? Yep, some people have said C, that is correct. So essentially A, the misoprostol, it can be used in PPH management, but it's not usually the first line pharmacological management. They might actually use it pretty early on to make sure that it can be used to maintain uterine tone once the tone has been achieved, but it's not your first line. Same with kind of the next option, although the next option, the dose is also wrong. It's the oxytocin infusion is 40 units in 500 mils of compound sodium lactate at 125 mils per hour. And then C is correct. So first line is either SINT, you can use Ergo, IM, or Oxy 5 to 10 units, slow IV, or Oxy 10 units IM. That's all in the prompt guidelines as well. In terms of carbaprost, it can be used as well, but it's not first line. And then the route is wrong. It's not intravenous. It should be IM. Oh, sorry, someone just asked regarding the units IV versus the infusion. The infusion is used to maintain uterine tone, so that's after. You know how miser is used to maintain uterine tone? It's the same thing. Well, yeah. Sorry, I think I moved the mic away. The reason it's not the infusion for the first line is because, well, one, the dose is wrong, but two, because that's used to maintain uterine tone once you've achieved it. Oh, okay. Does anyone have an? Oh, that's so nice. Yeah. Does anyone have an answer for question 8? Oh no. Yes, thank you. Does anyone have an answer for question 8? A, yep, that's correct. Oh, my slides aren't working. Okay, yep. So a cesarean section is recommended for women with placenta previa due to the risk of significant bleeding and hemorrhage because the placenta is over the internal os. So that's why it's A, and the prompt guidelines say that women with uncomplicated placenta previa should plan for birth before 38 weeks, usually between 36 plus 0 and 37 weeks of gestation. All right, I will pass over to.
Oh, my turn.
Okay, did anyone have any questions about the first 8 questions?
On the thing. Okay, cool. All right. Yeah. Okay, so this is next question, question 9. Yeah. Any takers for question 9? A? Cool. Who said that? What condition is this? Bonus question. Yeah, perfect. All right. Great. So firstly, you've got to recognize what condition this is, and the violin string adhesions are very characteristic of your post-PID Fitz-Hugh-Curtis syndrome. The other ones don't cause it. You just for you guys to know, chlamydia and gonorrhea are the top 2 ones that you should know that cause PID and can cause this. The other ones aren't, or technically can cause them, but aren't the most likely. All right, question 10. Anyone got an answer? B? Yep. Anyone got anything else? Confident with B? Why do you think it's B? Yeah, fever? Yeah, cool. What are some risk factors for this? For endometritis, sorry. Forceps? Yeah, good. No, you're right. I want you to be confident. How do I click next?
Oh, cool. You are correct. So just be confident. So yes, this person's got a fever. They're 10 days post normal vaginal delivery. She had a prolonged labor and also had forceps, which are both risk factors for postpartum endometritis. C is not correct. Usually the stem would give you something about a really high beta HCG. So in this case, she's also got a fever, which isn't really typical for GTD. So the subinvolution can cause delayed postpartum hemorrhage, but doesn't present with a fever. GTD usually comes along months later, and again, you'll have a beta HCG, which will be very elevated in your stem. Polyps are more of a chronic thing, won't cause this sort of presentation, and your septic pelvic thrombophlebitis is very rare, and again, won't come up. All right, so good. Just making sure you do know what postpartum endometritis is, how it presents, and those risk factors. All right, next question, 11. Someone in the Zoom has said A. Any other thoughts? Anyone got, everyone, do people agree with A? Yep, good, great. So for those that said A, you are correct. So low molecular weight heparin is first line. There's a lot of research that has evidence to say that it's safe. So it's given after birth or can also be given before. And it's important that it's also safe during breastfeeding. So regarding the other ones, DOACs don't have much safety data, so they're generally not recommended. C, again, doesn't have much data, so we're not going to use it. Warfarin can be used for long term, but what is the most appropriate for initial treatment in this setting would be low molecular weight heparin, and aspirin doesn't have any research to support that it will prevent DVT. All right, so good job. Question 12, looking at miscarriage. Give you 10 more seconds. E, we got an E. Anyone else got E? We got some E's? Yeah. Yeah, we'll go through. Does anyone, there was a question asked, how can you determine what it is if you don't know if it's a viable pregnancy? So we haven't had an ultrasound yet. Does anyone have a go at explaining how you got to E? E, yeah, cervix is open, yeah. What else? There's bleeding, yeah, good. So for those that said E, that is correct. Definitely an important concept to know. So the first thing when you look at this question is a cervix open or closed? You know it's open, so you can already cross off quite a few of those. So I'll go through each of them. So a complete miscarriage is incorrect. And a complete would have all products of conception have been passed. And in this case, we've mentioned twice that there's nothing resembling tissue and there's no tissue, which means it hasn't passed yet. A miscarriage is incorrect because we would have a closed cervix. So in this case, it's open, and we would have a non-viable pregnancy on an ultrasound. But again, we don't have that ultrasound data, but we know that the cervix is open, so it's not a miscarriage. Threatened miscarriage is incorrect because the cervical os is closed in a threatened miscarriage, and again, it's open in this scenario. Incomplete is also incorrect because there's some passage of a product of conception in an incomplete. So that's how you can differentiate the two. So inevitable, we know the cervix is open, we've got some blood, but we don't have any products of conception. So that's how you differentiate between D and E. Does that make sense? Yeah, awesome. So we don't need to, obviously in real life, you'd get an ultrasound, but in this case, you can already rule out quite a few of them because the cervix is open and there's no products of conception that have been passed yet. Question 13. Does anyone know yet? Give me an answer. C, we've got some confident C's. Anyone got anything else? All right, let's have a look. So great job. Why did you think it was C? Yeah. Yeah, great response. Awesome. So in this case, yes, we've got a miscarriage. We've already got a confirmed ultrasound that says it's a miscarriage. So we don't need to repeat the ultrasound in 7 days, and we don't need to have serial beta HCG tracking. That's not going to be required. What is methotrexate used for? Ectopics, great. So we're not going to use it in this case. And again, she doesn't need a suction D&C. When we're looking at this sort of scenario, what sort of things would make you do a D&C instead? Yeah, rural. Anything else? Yeah, preference, and I think hemodynamically unstable, someone said. Yeah, really good job. So in this case, she said she doesn't want to wait for it to resolve spontaneously, so we're not going to do expectant management, and she's stable, she's non-febrile, minimal pain and bleeding, and she's also 7 weeks gestation, so she qualifies for medical management. Really good. Okay, question 14. Yes. Any thoughts? D? Anyone got anything else? Why do you think D? Mm-hmm. Size of the mass? Anything else? Anyone got anything else? C? Someone said C? Wait, why do you think C? Who said that? Mm-hmm. Yeah, great. Beautiful. So this is testing your knowledge of ectopic, and knowing those criteria is important to know, unfortunately, but it's okay. Just go over them multiple times and it'll eventually get into your brain. There's a lot of 5s in there, so just remember 5. All right, so this is medical management. So looking at the criteria, she fulfills medical management. So she's clinically stable. She's less than 8 weeks gestation. Her serum beta HCG is less than 5,000. Her ectopic sac is less than 5 centimeters. No fetal heartbeat, minimal free fluid. So if she had any of those above those values, then she would qualify for surgical management. But in this case, she qualifies for medical. For expectant management, it's only an option if the beta HCG is less than 1,500 and they're pain-free and clinically stable. So you wouldn't do that. B is wrong because we said that is for miscarriage. D's wrong because she doesn't need to have surgery at this time, and we don't need to do expected management. It's pretty much a repeat of A. We just a few more extra things. We don't need to repeat the beta HCG with expected management. Does anyone have any questions about that? Yeah. Yeah. Well, to be fair, we haven't quantified it, but I would say no in this case. Like, if you look at all her values and all her results, it's all within the expected management kind of criteria. And usually would you say for surgical, you'd have to be quite unstable?
Unstable, we mean like hemodynamically, so they'll drop their blood pressure, they'll be tachycardic, and it'll be signs that they're losing their blood volume from blood loss is what unstable means.
Yeah.
The other thing to the line.
Yeah. So what was asked is the fact that she's bleeding, would that qualify for surgical management? And the answer was no, because if you look at the question, her vitals are within normal range. So hemodynamically unstable means her vitals would not be within range. So her blood pressure might be low, her heart rate might be going up. And also all her results are in keeping with a medical management criteria. All right. And the questions often aren't trying to trick you too much. I actually found in our ONG exam that they were pretty straightforward. So yeah, they won't try and trick you too much. So don't overthink it too much. But yeah, good question though. All right, question 15. Time? What's it? Yeah. Yes, question? Oh, is this for the SAC?
For medical.
I would go with prompt. I think they always would suggest go with prompt, to be honest. But I think in a question they would have to make it fair. So if Ranscock said something else, I would assume it'd be unfair for them to give you within the criteria. But Georgia's going to answer this.
In my notes from a couple of years ago, I've got for expectant management, the eligibility is that they have to be stable, pain-free, with an ectopic under 35 mil with no visible heartbeat and a beta HCG under 1500. So that might be where the 35 is coming from. But in general, I'd go prompt over Ranscock.
Yeah, I agree. Prompt all the way. Know those guidelines. All right, question 15. Any takers for 15? E? Great. So this is testing your knowledge of POI, premature ovarian insufficiency, and E is correct. That's the same question. All right. Yes, so E is correct. A is wrong because POI is defined as menopause before the age of 40. Early menopause is between 40 and 45. FSH and LH are typically elevated because they're trying to stimulate the ovaries. If you had low FSH or LH, that would really be seen in more of a hypothalamic or pituitary cause of amenorrhea. While POA does obviously reduce a woman's fertility, contraception is still meant to be used for 2 years after last menstruation. And D is wrong because although Turner syndrome is a cause of POI, it's actually not the main cause, often it's idiopathic or genetic. Did anyone have any questions about that? Right.
Great. If no one else has any questions about that, we'll move on to the next set. Do you want to switch? Great. Have a look at this one. Okay, do we have any ideas? I can hear mumbling, but I can't hear a specific. See? Yeah, that's right. So this woman is 51 years old, and it wouldn't be unreasonable for her to be experiencing perimenopausal symptoms. It's more the presence of postcoital bleeding that needs further investigation. So we'd want to do a CST in order to investigate that. Does anyone have any ideas of what we'd be looking for on the CST? Yeah. So we'd be looking for things like cervical cancer, ectropion, or polyps. And then in terms of the transvaginal ultrasound, we'd be looking for signs of endometrial hyperplasia or endometrial carcinoma as well. That's a good point. I think actually a better answer to this might just be speculum with appropriate testing, co-test. Because we're not only concerned about the cervical, like the test that we're screening for in the cervical screening test, we're just, like this patient might just have an ectropion that's causing the bleeding as well. So yeah, maybe co-test is a better option. Yeah, good point. Any other questions? Move on. Okay, what do we think about this one? Great. This patient could very well be pregnant, and it's important to exclude that before we treat for anything else. I think that's fairly straightforward. Any other questions? Otherwise, but that's like an easy thing. So every patient for sure. All right. Any ideas on this one? Yeah. See. Good. So this one is just about knowing when we do things. So for this patient, she would not need her OGTT done at this point. She doesn't have any of the risk factors that would warrant her needing the investigation earlier than 24 to 28 weeks. The table on the right is a screenshot from Prompt, I think, about the risk factors for early OGTT testing. The GBS swab you only do at 36 to 37 weeks. Cervical screening you only do if the patient is due to have that, and the pertussis vaccination is given in the second or third trimester, generally around the 20 to 32 week mark. Does that make sense? we'll move on. Any ideas? Yeah, I did just say the answer. Yep, so again, GBS is done at 36 to 37 weeks. CSTs are done at this gestation unless they are overdue. You do the Hep B testing at their booking appointment, so at 10 to 12 weeks. As I mentioned earlier, OGTT is done at 24 to 28 weeks, and you do ferritin studies at 28 weeks as well. These questions are, they're a little bit annoying in the fact that it's just remembering all of the tests and the booking appointments and all that stuff, but they're very fair questions for them to ask you. Sorry? I think they do your iron studies.
That makes sense.
But they definitely repeat at 28.
Yep, I think we're back.
Okay, so there was just a question about whether ferritin studies is done earlier. It is part of the booking guideline, the booking appointment. Is the screen about to, okay. Booking appointment bloods, but it is redone at a later point at 28 to 28 weeks, sorry. Great. Because we wouldn't have got from Okay, do we have any ideas for this one? C? Great. What does the membrane sweep do? How? Sorry? Yeah, that's right. So yeah, the vaginal examination and membrane sweep releases prostaglandins, which helps to induce labor naturally. So we do this quite regularly. I think if you've been to antenatal clinic and been able to sit in with a patient who's a little bit further along in their pregnancy, you would have seen this happen. It can be quite uncomfortable for the patient. Antibiotics aren't indicated for this patient. They don't have any reason to give them the antibiotics. Elective cesarean section isn't indicated at this point either. They're not further along enough for us to need to consider a cesarean section. Induction of labor is offered at 41 weeks, and you wouldn't do an ultrasound for growth and amniotic fluid assessment unless there was concerns. So if there was a drop in the symphyseal fundal height, reduction in fetal movements, or if there was concerns of oligohydramnios or intrauterine growth restriction, you would consider doing an ultrasound. But if this patient's just 40 weeks along and hasn't gone into labor, that wouldn't be an indication for an ultrasound. Does that make sense? Great. I believe so. I think it would be if the patient was of South Asian descent. We do have a lower, what is the word I'm looking for? Yeah. We do not like for patients of South Asian descent to continue their pregnancy for too long. We'll just have to double check how far along it is. But it would change your management. We'll give you the exact week in a second. Someone's just searching it up. No worries. Any other questions before we move on? Do you know why patients of South Asian descent we are concerned about? Yeah. Anything else? Good. Increased prevalence. Guys, you guys. Earliest gestation for membrane sweep. We will have a look at the earliest gestation for membrane sweep as well. And get back to you. Okay, we'll move on to the next question and we will let you know about the other two things shortly. That's fine. Okay, Georgia's going to explain the South Asian descent patient before we talk about this next one.
Sorry, we're frantically searching up prompt guidelines to manage to answer your questions. For the South Asian ethnicity, when do you offer induction of labour? According to prompt, you will offer increased monitoring from about 38 weeks, but your induction of labour is still like a 41 weeks, unless the fetal movements change. And then if you've got decreased fetal movements, then you're going into your DFM management pathway instead of your prolonged pregnancy pathway.
Okay, what do we think about this one? B. Yep. Okay, so there's a couple of things to think about with this particular question. This patient's been pushing, she's been pushing for 2 hours. which would be a delay in progression of labor. She's a multiparous individual, so we would expect her to have a active second stage that lasts an hour. So she's well beyond that. So we would consider doing a manual rotation at this point. There are important things to take into account. And even when you're doing an operative delivery, it's important to take into account maternal effort and well-being. Do we know which instrumental delivery require maternal effort and which ones don't? Yeah, so forceps require maternal effort. So if your mother's been pushing for 2 hours, she's really tired, she doesn't have the energy to continue to push, it's not a viable option and you wouldn't do it. You would consider vacuum at that point. Or ventouse, sorry. No, yeah, ventouse. I don't. I think you can do very mild rotations. I don't think you could change a baby from OP to OA. That's quite a dramatic thing to do with like a vacuum cup. I don't know if anyone's seen a vacuum, but a lot of it is just like outwards traction. Yeah, that's a fair assumption. If it doesn't say anything, that again, like Santina said, they're not trying to trick you. If they haven't said that there's no fetal distress, assume that there isn't. And same with maternal distress or maternal well-being. If they haven't said that the mum's really tired or something, you can assume that she's fine. Great. So I think you need less. Oh, it's the other.
If anyone's been to Jodie Keen's lectures, her quote was, "No pushy, no movie, no cuppy." So yes, you do need maternal effort. Forceps you wouldn't, because you can use more force, whereas with a vacuum you can't just pull the baby out without force. Because vacuum's a lot weaker than.
Okay, sorry, I got that the other way around then. Forceps do not require maternal effort. Vacuum does. Jodie Keen is the person to listen to. So she said that. Yeah, one, two, yeah.
So according to my Jodie Keen notes, there was a beautiful little table which said what everything's best for. So forceps, so normal forceps that are not rotational. So best for epidural plus prima gravida, or where birth not imminent and big bratty as fastest don't really need maternal effort. So forceps, you don't really need maternal effort. I guess that makes sense because forceps are a lot stronger than a vacuum. And then rotational forceps is for OP with no signs of obstruction. Just to know, forceps are really bad if you don't have analgesia. So that was in her bad at. So forceps are bad at analgesia-free situations. Pardon? Oh, and obviously really bad for a woman's pelvic floor. And then vacuum is best for outlet birth, especially in multigravida, rotation in multigravida without epi and good pushing. So no pushy, no movie, no cuppy. Jodie Keen loved that quote.
For the question on Zoom about augmenting labour, we don't give oxytocin to augment once the second stage has progressed. It's more like a passive or first stage kind of thing. If you're not progressing through second stage, then you need to figure out the cause, basically, before you give an oxytocin infusion.
There is a very clear sort of flowchart on prompt that you should follow in terms of failure to progress in labour. Great. Any other questions? Going to move on.
Give it away.
Wow, they got to be like, it's fine. It's fine.
They've got to, if they say it, they have to then give an answer.
Just while you read through this question, I'll quickly clarify a question I got about PPH before. So in my notes, I have 500 or more for vaginal delivery, and then for cesarean section, I have over 750 in my notes. And then regarding that, I think there was a question earlier about the a myomectomy for fibroids. So essentially you have like your different types of fibroids, like you have your subserosal, the intramural, submucosal, depending on where the fibroid is located. But essentially the intramural are going to be like in the actual myometrium of the uterus. So if you take out the myometrium, I think the hope is that you'll get rid of those like mass effect pelvic symptoms.
Yeah, I know. Okay. Me too. That's
Okay, do we have any ideas? Okay. Someone interpret this CTG. Okay, not interpret, just tell me what's happening. Okay, someone said baby dying.
sounds like Big Brady. Big Brady.
Yep. Yeah, that's all that's really happening in the CTG, to be honest. So the answer is E. I don't know where I'm struggling with. Okay, so just quick refresher, the top line is fetal heart rate. So prior to the drop, the fetal heart rate was sitting at about 140. And we've got a big drop that's lasted more than 5. Oh, well, it's lasting for quite a significant amount of time. So we're concerned about sustained bradycardia. What are we worried about when we are thinking about sustained bradycardia? Yeah. Yes, so we had hypoxia. Yeah, so what sort of causes a hypoxia?
In this case, and the point is in some function.
Mhm. Yeah, so yeah, we can be thinking, so hypoxia is the thing that we're concerned about here. We're concerned about things like umbilical cord prolapse, placental abruption, uterine rupture, and then from a maternal point of view, we're also concerned about hypotension and hemorrhage. So essentially, if there's a loss of blood supply to the baby, there's going to be a loss of oxygen to the baby and therefore hypoxia. This is an emergency. You have to take this patient to theatre and you have to do an emergency C-section. There's sort of no in between steps that you can consider, aside from maybe if on examination there is evidence of cord prolapse, then you would consider getting the patient to get on their hands and knees. But I think at that point you would still be quite concerned for the fetal well-being, and if the CTG doesn't correct with that maneuver, you would move on to a code green emergency C-section. Question?
Just at the start, but just like you see the decrease in the heart rate, what would you do then? Like it's been like 30 seconds or like are you just repositioning?
So there's just a deceleration in the CTG. Is that? I think, so there's a couple of decelerations that you expect to see, right? Like variable decels is, you'd expect to see that in cord compression. If that's prolonged, then that would be concerning for fetal well-being. And if it's definitely, like if it's continuing to sit at if you know that the CTG was showing that previously the baby was like the heart rate was 140 and now it's reduced to 80, something's wrong, right? Like that's like the baby's not okay. And so I think you would definitely, at the very least, consider calling your consultant and doing something about that. You wouldn't just let the baby continue to have a heart rate at 80, because that, even if it's not immediate hypoxic injury, prolonged heart rate of 80 is going to cause some sort of damage, and you do something about that for sure. Any other questions? Great. Jojo?
All right, have a go at this one. Any takers? Any guesses? Got some A's? Great. Cool. Who said A? Would anyone like to tell me why it's A? Multip is 1 hour. Good. Yeah. Yeah, nice. So second stage, less than or up to 2 hours. Multips, we've said 1 hour. Epidural won't always prolong second stage. Obviously, the descent of the presenting part is very helpful to tell us about second stage, because the head's obviously not going to come out unless it's gone down. And oxytocin infusion, we said before, it's a first stage augmentation. You don't use it in prolonged second stage. Was that an answer? Any answers? Any takers? Getting some C's. Do you want to tell us why? Anyone? Vibes based. Can anyone tell me what you've noticed in the stem? Pardon? Foul smelling discharge. Good. So she's tachycardic, hypotensive, febrile with foul smelling discharge, and she's got decreased fetal movements. So choreo. Great. Nice. Any takers? Any guesses? Getting some B's? E's? E's. Why? Who would like to?
sounds like they've got chickenpox.
Good.
Chickenpox and varicella, so you worry about varicella, general varicella, which
Why not neonatal chickenpox?
that 18 station, so like.
Yeah, good. So for those on Zoom, we have someone who sounds like she's got a chickenpox rash. So she's got like kids who've had the rash, which would be a risk factor. The erythematous vesicular rash is quite classic. So you're worried about some kind of chickenpox affecting the baby, but she's 18 weeks gestation. So if you get infected under 20 weeks, the risk is congenital varicella syndrome. Whereas if it's closer to delivery, then you're more worried about neonatal chickenpox then. Syphilis and rubella don't present like this. And herpes is more like it's acquired during birth through the vaginal tract. And the story doesn't quite fit a herpes picture. Neonatal chickenpox is if you get infected closer to delivery. Let me double check. I did write down the timing. I've got 3 weeks prior to delivery in my notes. Any takers? C's, some D's. Any more takers? Would anyone like to explain their reasoning?
No.
7.8 should be sufficient to diagnose GDM. Any other thoughts? So this one is actually OGTT. The cutoffs for GDM at 24 to 28 weeks, sorry, is a fasting greater than 7, a 1 hour post glucose of 10.6 I've got, or 2 hours greater than 9 or 11. So I don't think you can diagnose off a random. You need to repeat the OGTT because she had her early one because of elevated, like of risk factors, but she needs the second one. And you have to confirm the diagnosis before you start your management. Any takers? All right, someone from this half of the room, give me an answer. Doesn't have to be right. B? B? Okay. So once you have been iso-immunized, there's no point giving anti-D anymore. So that takes out B and D. This is quite mean because you do need to know what a high titer is. So 1 to 8 is a low titer, so you will monitor it. So repeat your antibody titers and check for a rise. Once you hit a certain threshold, I think prompt says 1 to 32, but I think that would be quite a mean figure for you to know. But say once you've got a higher titer, then you have to do your bi-weekly MCA PSV monitoring, consider your transfusion. And obviously you're not going to do no action on an iso-immunized person in pregnancy. Any questions on that one? It is quite mean. Yeah. They are iso-immunized, but it's a low titer. Yep. You start your bi-weekly monitoring with your ultrasound MCA PSV with consideration of transfusion if needed. Yep. So she had mild vaginal bleeding at 6 weeks. So she's had like a antepartum, well, I don't know if you call it antepartum, but she's had a sensitizing event because anytime you have vaginal bleeding, there's a risk that your fetal and maternal circulations like cross and you get exposure. So the maternal system will make antibodies to the fetal cells. So that's when you're checking your antibodies in a group and antibody, you're seeing if a rhesus negative mum has made antibodies to the cells of her own fetus. So once you've become, once you've got those antibodies formed, you can't undo that. So the anti-D that we give is to prevent iso-immunization from happening in the first place. But once it's happened, giving the anti-D injection isn't going to do anything. So you don't do it anymore because it's a prevention thing rather than a treatment. Yeah, normally. Okay. We'll have to get out, refresh, and then. Sorry. We're back. We're getting there. Sorry, what was the rest of the question? Oh, so the algorithm is if there's a maternal bleed and you're worried about a potential event where fetal and maternal circulation could have come into contact with each other, they'll do a Kleihauer to test whether there's fetal cells in the maternal circulation. And that's like the acute side of things. The chronic, like, has it happened without us realizing, is your group an antibody. And if it's positive, then you're iso-immunized. Okay. There was another question up here. Okay. Okay, cool. Any more on iso-immunization? I know it's a tricky one. Cool. Was that? No? Yeah. All right. Someone from this half of the room now. A? Oh, we've gone off. Correct. Good job. Would you like to have a go at talking me through your thought process? Mm-hmm. No, that was really good. So the answer for those on Zoom was that we've got a picture of PCOS here. From chronic anovulation, from the irregular menstrual cycles, you get high rates of high estrogen, and your unopposed estrogen then increases your risk of endometrial hyperplasia and carcinoma. Osteoporosis is from estrogen deficiency, so in postmenopausal women, and the rest are kind of not really related. Does anyone know the criteria for the diagnosis of PCOS? Rotterdam, great. Would anyone like to tell me the components?
Sorry. I'm microphone shy. Oligo slash anovulation, clinical slash biochemical hyperandrogenism, and also ultrasound findings of cysts. Over 25 bilaterally or 12 on one side. Oh, 2 out of 3 the criteria. Yes.
Great. Good job.
And yes, the key with this one is the unopposed estrogen.
Oh, we have to. Sorry, we've made a question change, so we just need to refresh. You're going to have to share again. Oh. Okay, question 29. All right, any takers? We'll go this half of the room again. A? D? Anyone else? What was that? A? Oh my God. Let's find out. D. So we've got a null up in active second stage, but she's got some complicated variable D cells. We've got good maternal effort and fetal descent, but we're a bit worried about the baby. So vacuum is the answer.
So also with this question, she's only using nitric oxide, so that's a no for forceps. So just the key points to know here is that, yeah, no analgesia, so we don't want to do forceps. She's got a really bad CTG. We need to get this baby out. So maternal changing is not going to help at the moment. We need to seriously get a move on. And she's got good maternal effort. So again, remember the quote from Jodie Keane, no pushy, no movie, no cuppy. We've got good maternal effort. We've got some pushing, get that vacuum. And hopefully get this baby out safe. So just remember those key points.
So complicated is the key word here in the variable D cells. We'll accept some variable D cells, but as soon as they become complicated, we're starting to worry about baby's safety. Yeah. I think, yeah, so forceps, you need to have better analgesia, but Bontus, my understanding is that you can get away with less. You got to put it, you got to get the, you know, not a great image from me, but do you know what I'm trying to say? All right, last question. All right, any takers? This half of the room, this side, this time. B? Huh? B? B? Getting some Bs? Why? Non-16, 18 Elch cell. Great. Nice. If it was 16, 18 HPV? Cope. Great. Nice. Good job, guys. That is the end of the Mogi questions. We will be releasing an MCQ pack that will have an extra 30 in it. We've got a drive full of lots of resources. We've created approach 2 fact sheets for your history pluses, so get around them, and there's some PSPs from multiple years in there as well. So good luck.
All right. Might wait for people to come to their seats, but in the meantime, I'm going to go to the next slide. So my name is Keith. I'm the final year rep for GPSN. Wrote a lot of these questions, and I'm also here with Hannah, who's one of the co-chairs for us as well. Just before we get started with the questions, we're sponsored by MIPS today, who are doing a $100 gift card giveaway. So this is eligible for anyone that's here at the lecture right now, if you're here in person or on Zoom. So if you just sign up using one of these QR codes, the left one is for the 4C students here, whereas if you're one of the final years that might be facilitating or whatever, you can use the QR on the right. It's a free thing to just sign up for, and the draw will be done tomorrow. So again, it's only out of people that are like here or that will scan the QR code tonight. So it's kind of a high probability of actually getting this. In terms of, I might just talk to the type of questions to expect with GP. I've been discussing it a bit with other people, but compared to the other disciplines, a lot of GP it'll be like kind of 50-50 with some of them being diagnosis oriented and then others you kind of have to figure that step out first and then figure out the most appropriate management next. A lot of the key principles are kind of like what can you do in a GP practice versus what do you need to escalate elsewhere to. So that might be specialist input, that might be escalating them to go to hospital, and knowing what sort of things can and can't be done at the practice in the meantime, especially for your emergencies. So just having some of those principles in mind will be good. Okay. How many do I have on Zoom? 26? Do you want to just start? Okay. I might give people a couple more minutes to trickle back in. I might as well talk about the history plus as well. From a GP perspective, one of the big things that they like to keep an eye out for are the chronic long-term management principles, stuff like your screening, immunizations, things that can be applied in the long term. So one thing I've been suggesting to people when you're saying your explanation of a diagnosis to your patient and you're breaking up your management, you might think about what can you do acutely versus say what you can do in the long term. So what are we going to do right now? And then addressing your risk factors, for instance, specialist follow-up, and then more general, broader lifestyle things like SNAP-W or whatever. Okay, shall we get started? Yeah. All right. Again, we'll repost these QR codes after the lecture as well. So if you want to sign up then as well, that's totally fine as well. Cool. So we've got our first question here. 24-year-old female, 2 days. Looking for the most crucial step. For those on Zoom, you can just type through answers if you'd like. And if you're here in person, you just call them out. Did I hear an E over here? Yeah. E or B? E's. There are a couple of things that are pretty reasonable, I guess. But there's also the keyword here of what's most crucial in terms of what we should do right now. E. Cool. So for this one, E would be our answer here. I was hearing a lot of B and E. So in terms of why we're not doing A, what do we think is going on here, first of all? Meningitis, good. So in terms of what we're worried about, photophobia, neck stiffness, there's a rash that's blanching. This is all pretty significant for meningitis. The key thing for us is that, first of all, this is not something that we can just manage on our own. This person should be going to hospital. So probably need to be leaning towards one of either B or E. And in terms of these two answers, the reason why we're going with giving them the IV KEF or benpen and then going to hospital first versus this like neuro and then going to an LP and ED is that giving the early administration of the antibiotics is really important for meningitis, even if the LP actually takes a while to happen. So you want to prioritize doing that if you can, and especially in the GP clinic, that's going to be really important. Yeah. Obviously, you could consider doing like the IV KEF and the neuro exam. That's not unreasonable. But in terms of these two answers, given that B doesn't have that as part of the management, it's more important to do that. Yeah. The blanching rash is in keeping with meningitis. Yeah.
Meningococcal meningitis is the one that you're very worried about, and that's typically a non-blanching rash. That would be the buzzword for it as well, but it can start off as blanching.
Cool. Any other questions from the crowd or otherwise? No. All right. Next one. 68 years old, no history of. Any thoughts from the floor? Hearing D. Any other answers? D. Had a couple of answers for D. Any other thoughts? D or A? Okay. Haven't really heard much else outside of D. Why did you go with the D? What are you thinking?
Bit more trauma fracture here.
Mm.
And I'm not sure. I think spinal trauma is enough to diagnose the osteoporosis.
Yeah, pretty much. So the answer here would be D. The reason being, osteoporosis, we have a couple of ways of diagnosing it. The first one is with our DEXA scans. What are the values we would want to look out for osteoporosis? Below 5? 2.5, good. Yeah. And then between 1 and 2.5, we're thinking about osteopenia instead. So technically the T-score falls into that, but the other point that's been raised here is the fact that this is a minimal trauma fracture. So a pretty innocuous fall that's led to a significant fracture. We're a bit worried about that, so we should just start on the bisphosphonate from the get-go. Any questions with that one? Yes. It's a good question. So the question was, do you have to wait for the actual fracture to heal? My understanding is no. I think you can just start it from the get-go and it should be fine. Do you have any other thoughts about that, Hannah? Yeah, to be honest, it's not something I've heard explicitly discussed. Obviously, this is a bit missing from this in terms of the time frame for where or like when that actually was. Yeah, I think it's fine to go from the get-go. Yeah. But obviously your fracture management would be another part of what you'd be doing here as well. This is just purely from an osteoporosis side of things. Cool. All right, let's go to the next question. I'll go back to question 2 after looking at this. What are we saying? E? Great. No one wants to send this person home? Okay, good. So we're a bit worried about this person. It's been 90 minutes ago, so the time frame for TIAs is within an hour and then resolving. Yeah, please don't send this person home. They're probably having a stroke. Get them to hospital with an ambulance. All of this other stuff is like stuff that you would maybe consider in the long term, but this person's having a stroke right in front of you, so please do that and get them to hospital. I'm just going to go back to question 2. There was a question about whether you treat this because they're osteopenic. So 1.5 for the T-score is in the osteopenic range. However, so if it was just that, you wouldn't need to do the bisphosphonate stuff. You could focus on your lifestyle management, supplements, that side of things. But because of the minimal trauma fracture, where they've just had a fall and then the fracture itself, yeah, it's because of that that we're a bit more worried, and then that's more diagnostic of the osteoporosis. Other fractures that you might consider are like compression fractures of the vertebral spine. That's pretty common as well to look out for. So keep that in mind with these patients that could be osteoporotic versus osteopenic. Okay. Yeah. So that answer for question 3 was E. Thoughts? B? Anything outside of B? Okay. 5 from here is B. B online. Yeah. So for this one, it would be agranulocytosis. Another key word here is life-threatening, where we're very worried about that. Other medications that can cause this are clozapine and carbamazepine. This is just something that you may need to know. But yeah, all of these other side effects outside of the weight gain are associated with carbimazole, but in terms of what's actually the most worrying thing to keep an eye out for, agranulocytosis. Okay. Brilliant question. Um, yeah, look, that might have been an oversight when I was writing this question. Apologies. My understanding is I think they will give you the reference ranges more often than not. But that being said, despite that there's no reference ranges, maybe that's a hint as to what we can still do. What was that? D? Have a couple for D. Any others? Was that D as well? E. Okay. Sure. Cool. So yeah, this one would be D. Again, keyword here is initial. So they have all this cholesterol stuff. They've got hypertension. It's a routine checkup. So we can just use this cholesterol stuff to actually look at their risk, and then that can help stratify whether we need to start them on lifestyle stuff, whether we want to start them on a statin as well. So A would probably not be unreasonable. I can't remember what this guy's stroke risk is when you calculate it. Oh, there's probably some missing information here actually. In terms of the other options here, again, when you start like these more chronic medications, you don't really need to go high intensity off the bat unless they're like really, really badly deranged. Fibrates are going to be our second line stuff, and then you wouldn't really be escalating to that third line of this stuff as well. Ezetimibe is another one that would also be in consideration for the management of stuff. Okay, next up are off-that questions. I heard a C from somewhere over here. Other thoughts? C? What do we think is going on? I'm hearing glaucoma from over there. Any other thoughts outside of C? Noted the D on Zoom as well. All right. So for this one, this is actually E. So I heard a couple of people mentioning glaucoma, which isn't unreasonable to think about, but the thing to look out for here is the actual shape of the iris right here. So this is pretty misshapen, and we're a bit worried about anti-uveitis as our kind of top differential here. One of the mimickers that this can be is like ocular syphilis. That's a thing. But ultimately, for someone with anterior uveitis, they need to be seen by ophthalm urgently. C and D, my understanding is that these are kind of our first line management that can be considered for acute glaucoma. So for those of you that were thinking down that pathway, that's not unreasonable. But ultimately, this person needs to be seen by ophthalm for a slit lamp urgently. Anyone know what the? Oh yeah. I did not notice that. Could be the is that like paralimbal sparing? What do you think? This, like this thing here, compressed on the inside of the actual anterior chamber. I think it's getting at the fact that the anterior chamber is affected. So there's something maybe going on here as well that could be compressing on the iris itself, which is why that's all like misshapen. But again, I think the fact that with glaucoma you're thinking about like a what is it, like fixed dilated pupil or whatever. But because there's this misshapen pupil, we're a bit more worried about anterior uveitis, which is something that needs to be escalated. Anyone want to just yell out what that would consider in terms of management for anterior uveitis? Yeah, topical, oral, topical steroids. Good, cool. Toughy question. Any thoughts from the room? B? Yeah, B. What was that? A B on Zoom. Any other thoughts? Okay. Yeah. Whoops. There we go. The answer's B here. What led you to going with B?
It's the macular degeneration, so more central vision that gets.
Good. Yeah. So macular degeneration is loss of that central vision first. Something like cataracts would just affect your vision globally because that's going to be the lens affecting everything. And yeah, wet mac degen would be a bit more sudden, whereas dry can be just age related. Thoughts? see on Zoom. I think I heard an A somewhere. I hear an A over here as well. Any other takers? D from somewhere. Okay, a lot of variation with this one. I think when I was going through these questions, I also got it wrong. So the answer here is D. A bit of a toughie. There's a few things to kind of potentially break down here. With blepharitis, which is affecting the eyelids, is there anything, how do I phrase this? How might you break it down in terms of the symptoms that you could get with blepharitis? Yep. Yeah, good. Do you know why the extension, why it's associated with rosacea? Yeah, that's fine. I didn't know until a week ago. So with blepharitis, you can break it down into whether it's anterior or posterior. With anterior, the symptoms you get are going to be like gritty eyes, all the stuff that's affecting kind of the eyelids. They get discharged and that side of things. With the rosacea, that's something called posterior blepharitis, which is to do with the actual, what's the name of the gland? Meibomian. Yeah, meibomian gland dysfunction. So as a result of that, they get the facial flushing. So it's rosacea secondary, or like they're kind of associated with one another. So that's what's pointing it to the blepharitis, is that there's actually like this anterior and posterior stuff as well. I don't think that, say, like, I think the allergic conjunctivitis isn't unreasonable to think about as well, but it's because it's associated with this rosacea that it's a bit more likely to be the blepharitis picture here. Any questions with that? Nope. Cool. Oh. Oh. Hmm. All these contacts, man, overrated. Just wear glasses. Just get your, just have good eyes. Oh, sorry. Okay, well, I wanted to hear my answers, but answer here is D. So contact lens wearers, a red painful eye with this corneal ulcer, until we know what's going on, is pseudomonal keratitis until otherwise proven. So we need to start with intensive topical ciprofloxacin. That's the management for this. Yeah, keep an eye out for if someone wears contact lenses. Don't wear contact lenses. And they also need to be seen by opthal urgently too. Okay, one more opthal question. Be on Zoom. Thoughts from the room? B. Anyone want to do an MRI? Nah. Sorry if you said that. Okay. So for a corneal foreign body, as part of our management, we need to stain and actually visualize where this body is. Yeah, that's just going to be our next step with the slit lamp. Cool. All right, that's it for the opthal questions. Let's move on to derm. I wrote these questions, so sorry in advance if some of them are like kind of ass. This is what I'm saying. Like, I wrote like not appropriate as initial management. Like, what am I doing? Okay. To start off with, what's the kind of prevailing diagnosis here? Great. You probably don't need to read the prompt to figure that out. So we've got psoriasis as the primary diagnosis here. The next question is, I guess, how do you manage psoriasis from the get-go and what options do we have? Thoughts? I'm hearing B. Yeah, not appropriate. Any other thoughts? We have one for B. One for D. Any other thoughts? Okay, we'll move along. So the answer for this one is BPO. Everything else can be involved in part of initial psoriasis management. Yeah, I might just explain it myself. So corticosteroids, I think when in doubt, derm corticosteroids probably makes sense. But tar and salicylic acid can be given together as like an alternative to that. So if they're not very good with topical steroids, that is another thing that we can consider as well. They work well together. And then the calcipotriol, which is like a vitamin D analog, is something that we can use a bit more kind of longer term to help with the buildup of the plaques themselves. So in reality, it's probably like they'll get steroids and the calcipotriol, or like tar salicylic and the calcipotriol. But those are all options. BPO is something that we more often use for acne. Sorry. I heard an oh no. Yeah, I channeled my inner Jen. What's her name? Jen O'Neill? Anyway, but for D, what was that? D? Any other thoughts? E? C? I'm hearing every letter of the alphabet. All right, let's go into the actual answers here. So this one's E. This is just one of those things with melanoma that you maybe just need to be a bit aware about how much is your margin and whether you need to do sentinel node biopsies. So if it's just in situ, we can do a 0.5 centimeter margin, no need for our lymph node biopsies. If it's less than 1 millimeter, so it doesn't have to necessarily be in situ, it could have gone and penetrated, but it's still less than 1 millimeter, then we're going to about 1 centimeter margin, but we're still not doing that lymph node biopsy. When it's between 1 and 4 millimeters thickness, the margin, there's a bit of room to move with it, but it's 1 to 2 centimeters plus or minus a sentinel node biopsy. And then if it's greater than 4 millimeters, you're going to go with a wider margin, 2 to 3 centimeters, and you're definitely doing the sentinel lymph node biopsy. The reason why this one, because again, there's a lot of gray area in this, right? Because 3.2 falls into that 1 to 4 millimeter range. When it comes to melanoma, you're often, even though it's a range of 1 to 2 centimeter margin, you're more often than not going to err on the higher end of that. So you're more often than not going to be doing the 2 centimeter margin. And because it's in that higher range of the normal, sentinel node biopsy is something that's advisable because we're really concerned about this. So yeah, realistically, in the real world, if it's because it's 1 to 4, but if it's in that higher end, you're probably going to go with the 3. Okay, but again, all right. Next one. again, I'm going to stress here, this says most inappropriate, so the worst option. Please bear that in mind. Sorry. It's a school thinking, you know? No, it's because I've been doing so many of those questions that like, it's been infiltrating my mind. What are we thinking, guys? D on Zoom? Any other thoughts? D as well from here? C? Anything from this half of the room? Thoughts? Nothing. Okay. Seems like this one's a bit contentious. So the answer for this one is the erythromycin is not part of the first line in terms of the options. So we've got acne here that's on the back, which already indicates that this is more severe. It's like a moderate severity plus. So yes. Sorry, I can't hear you. What was that? That is a good point that you've raised. My understanding was when I was writing this question that you can use Diane 35 as an option, like for dual function. It's not as good as the contraceptive function as you were saying, and it's more for the acne from a hormonal therapy. Hmm. It's not good enough for contraceptive on its own. Yeah, that's a fair point. I think again, it's most inappropriate. I'll get to why erythromycin is the most wrong. Probably in this case, if you were to switch the oral contraceptive, that wouldn't be enough on its own. You would need to have a further discussion about something else. So you could say like, we could switch her to that plus do something as well. But in terms of actually treating the acne, I guess that's better. It's not as good for the contraceptive as you mentioned though. Good point. So in terms of the other options here, oral antibiotics, specifically doxycycline, is our first line for acne. But some of the other options that we can consider are spironolactone, which funnily enough works. Don't ask me why, it just works. Erythromycin, specifically, we only really use that if they don't really tolerate doxy. So it's a second line. As for anyone that might have picked E, when it comes to isotretinoin, we often think about that as like that's reserved for our severe acne. And there's a few different ways that acne can be severe. Scarring, psychological distress, a few different reasons. The reason why it's not inappropriate is that it probably takes a while to get a dermatologist. So you could probably still just do the referral anyway, and then they can consider if they actually want to pursue that themselves. Yeah, the most inappropriate here is erythromycin. Sorry about a most inappropriate question. Okay. Never let me be never let me write exam questions. See, I'm hearing a lot of C's. See? Any other thoughts? B, I'm hearing B from this side of the room. Any other thoughts between B and C or otherwise? Oh, go on. Heard another B. What's your final answer, Calvin? Do you think C? Calvin thinks C. The answer is B. So most people were considering between B and C. So in terms of why it's not the others, urticaria, wheals, doesn't really fit that picture. Atopy and seborrheic dermatitis are more endogenous, and seborrheic dermatitis is like, dandruffy. So not really going to be on the fingers like that. So my bad. Okay. In terms of why, or like what the difference is between allergic and irritant contact dermatitis, this took me a bit of time to actually kind of think about it specifically. But the reason why it's allergic, so for a lot of people, you can get like nickel exposure or like jewelry products, nail cosmetics. There's a few different things that certain chemicals can quickly give them that kind of allergic contact dermatitis. Irritant contact dermatitis is to do with the specific like toxicity of the chemical itself, whereas an allergy thing is it's like something pretty innocuous that shouldn't really cause that reaction. Why it's not irritant contact dermatitis is that you can split it into either is the exposure a low grade or a high grade? High grade being kind of like chemical spill type thing, low grade being something not so bad. But if it's a low grade exposure, it needs to be over a long period of time. Whereas if it's high grade, it's an acute thing. So then they get the dermatitis from that itself. In this case, it's something pretty innocuous, being a new ring that they've started wearing, and then they're getting the rash as a result of that. Which is why it's pointing a bit more to an allergic contact dermatitis, not irritant. Were there any questions with the difference between the two of those? Again, a bit of a tricky one. If the case was something like someone was wearing a ring all the time over years and then they had this sort of rash, you might be thinking more irritant because it's not to do with the actual things in the ring itself. It's to do with the constant friction that's causing the irritant contact dermatitis. Right. One more derm question. Irritant contact dermatitis can be sudden, but it should be associated with a kind of high severity exposure. So something that's like a chemical spill, something that's really, really toxic acutely. So it can be acute, but you would want to have some history of them being exposed to said thing. Something like a ring would not result in that. No, that's okay. No need to be sorry. So again, yeah, irritant. It can be either something like friction over a long, long period of time. That's like a low grade thing, but chronic. Whereas something that's a bit more higher intensity, like a chemical spill, like very intense heat, that's where that would be. Okay, we have an answer for B here. Again, the key word here is not play a role. Sorry. I've got a habit of that. I've got to stop, man. Anyway. No worries. I swear, this is the last question I wrote, and then I'll pass over to Hannah. Any other thoughts? We have one answer for B. No, we love a good recipe question, don't we? Yeah. Now, the off-the questions did my head in, and then the derm questions were just poorly written by me. Here's the thing. You write that damn easy, right? That's the thing. Yeah. Whereas Julia. Hold on. It's good. And anonymous. Any other thoughts? We had one answer for B. C? I mean, C? C? Yeah. Nice. Answer here is C. In terms of what we do for our shingles, topical antivirals don't really get the job done. we might use them more in something like HSV. Everything else here is pretty reasonable, so we'll go with some oral antivirals. Anti-itch would be good for the symptom side of things, as well as analgesia and then protective ointments as well. So these are all the sort of things that we can consider in shingles. But again, topical antivirals don't really have that good penetrance. We want to go with something a bit more systemic, so going with something oral. Sorry, my bad. Okay, I'm gonna handball over to Hannah now.
All right, guys. The next topic is RESP, so hopefully this will be a nice break from ophthalmology. Starting off strong with a spirometry question. Any thoughts on the diagnosis here? Yeah. So does anyone want to tell me how they would read this spirometry result? / what makes you think it's asthma? Yep, exactly. And with the post-bronchodilator respiratory response, it's got to be either 12% or 200 mils, which is the definition, which is true in this case. Bronchiectasis, not usually a spirometry picture, but you would often get more of a mixed picture or a restrictive disease. Normal spirometry, no changes. And then COPD, obstructive, but you don't get as much of the post-bronchodilator response. No. Any thoughts? What are we doing for this patient? Yep, I'm hearing some Bs. Anything else? So the answer for this one is B. So we would start him on a long-acting medication, whether that's a LABA or a LAMA. So I'm not sure if you guys are familiar with the stepwise management. So for COPD, we start with a SABA or a SAMA, and I think he was on that SABA. And then the next step up is a LAMA or a LABA, which would be tiotropium. The ICS is not really recommended in COPD, especially not as a monotherapy or alone with a SABA. That's triple therapy for people with frequent exacerbations, and there's a pretty strict kind of requirement they have to hit before you're adding that. And then smoking cessation and influenza vaccinations are very important, but it's not going to manage his symptoms. This one's a bit buzzwordy. Anyone remember? Yeah. I think I was hearing some whispers of B. So yeah, that is correct. This is Klebsiella pneumoniae. So there's a few buzzwords in there, being it's a right upper lobe, and the heavy alcohol use, which is often associated with aspirations that cause this cavitating lesion, and that's why you get this blood-stained current jelly sputum. In terms of the other ones, yeah, there's just a few buzzwords associated with them. So Staph aureus is typically post-influenza, and it's in IV drug using populations, and it also causes that cavitating abscess. Legionella is often from a potting mix or soil exposure. Pseudomonas is more like for your cystic fibrosis or bronchiectasis patients. And Coxiella causes Q fever, and that's when you're thinking about farmers or abattoir work exposures. Was it something I did? Okay. All right, we're back online. Any thoughts for this question? Oh, it's coming. Yep, so I think I heard a D. Any thoughts why D? Yep. And what's making you think it's severe? Yep, so high resp rate, he's confused. Is there a scoring system you could use? Yes. Yeah. So I think this one's pretty well suited to curb 65, especially because they have labeled his urea as well. You don't always get that. So yeah, the answer for this one is D. This is severe pneumonia. Definitely some worrying features. Here, I don't think, is it in here? No, I didn't put the curb 65 scoring in here. But for curb 65, yeah, his resp rate is elevated. His blood pressure doesn't meet the requirements. I think it's under 90 systolic, is considered low blood pressure with curb 65. But yeah, he has the elevated urea as well. So yeah, oral amoxicillin outpatient, will be for very mild pneumonia. You add doxycycline when you're worried about atypicals, and then benpendoxy is going to be moderate, and that's probably going to require a hospital admission anyway, just because they have the IV antibiotics.
It's not bad, but I remember seeing this question. I was like, I don't know. Yeah. Do you know all the questions yourself?
Yeah, we recall.
Oh,
Released it. Yeah. So the question.
okay. Yeah. Yeah, I just forgot about it. I didn't even think. Yeah, well, I don't think. Really? You don't have like an academic offset. It's more like just the offset.
Any thoughts on this question? It's a bit buzzworthy again. C? I'm hearing some C's. Yes. So yes, this is small cell carcinoma. We have a central lung mass. You've got the hypernatremia. So do you remember which paraneoplastic syndromes are associated with small cell carcinoma versus squamous cell? Any thoughts? Yes, yeah. So SIADH is with small cell carcinoma, and then squamous cell carcinoma, you have the parathyroid releasing, paraneoplastic syndrome. So you get more of a syndrome of hypercalcemia. The adenocarcinoma is most likely associated with non-smokers and it's more central. Same with the large cell carcinoma. Large cell carcinoma, it's more peripheral, but it is poorly differentiated and can cause gynecomastia. And then carcinoid tumours can cause flushing from serotonin syndrome, but it's quite rare. All right. And then Renee's and Weber's question. These ones are pretty popular with the GP exam. You can pretty much expect one. I feel like I'm hearing some whispers of a D. Any other thoughts? So for this person who said D, do you want to explain your answer, or is there any, any thoughts on terms of why, how you got to that conclusion? Mm-hmm. Mm-hmm. Yep, perfect. Yeah. So yeah, you always have to combine the two tests. You went Weber's and then Renee's. I tend to do the opposite. So yeah, for those who didn't hear, air conduction over bone conduction, that's either normal or sensory neural. You rule out a conductive hearing loss. And then Weber's lateralizing to the left, that's abnormal. So that's a pathology. And in that case, we've only got sensory neural as our pathology, and that will always lateralize to the good ear. So therefore, you've got a loss in the right ear. I think these questions just take a bit of practice. This one is also another very classic GP presentation. What are we going to do for this little boy? Anyone committing to an answer? Yep. I'm hearing some Bs. Why B? Yep. And what would some of those indications for antibiotics be? Yep. Yep. Awesome. Yeah, so for those who didn't hear, the answer for this one is B. Like otitis, this is very clearly otitis media. We've got that bulging tympanic membrane, and we don't routinely treat them with antibiotics despite what parents might come in believing. And that's because the evidence sort of shows that it doesn't really reduce the number of days to improvement. And so for that reason, the best thing is just to leave it and follow up your patient closely. There are some indications for antibiotics which were mentioned at the if they've got bilateral, if they're under 6 months as well. And it's worth kind of being a bit familiar with those. Yeah, so if they are Aboriginal or Torres Strait Islander, if they're under 6 months, if they're under 2 years, but if it's a bilateral infection, if they're systemically unwell, those ones are the main ones. And if there's any complications, so if they have like mastoiditis or perforation. Yeah, an otorrhea. Yeah, which you'd get with the perforation usually. Oh, sorry, there was a question. Yes, so you can give antibiotics if they're not improving in 2 days. I don't know if that is like a definite. Rikith, do you have to give antibiotics if they're not improving in 2 days?
I think, yeah, generally you would see how I think it's after a few days, so like 2 to 3 days. And if it's still persisting, then you might be a bit more worried and then you would consider it. Um, yeah, I think often you would follow up with the family and have the kid come in and see how they're doing, if they're about the same, if they're better, if they're worse. And then from there decide. Yeah, I think it would be after a few days.
Yeah, it's normally self-resolving in 7 days, but it can take a few days to see improvement. So sometimes, yeah, I wouldn't necessarily commit to antibiotics if no improvement in 2 days. It may take like 3 or 4. It's more, if they've got a persistent fever, if they're very systemically unwell, that's, yeah, you using your clinical reasoning there. All right. This one is reading some audiometry results. Yep, I think I heard a B. Any other thoughts? Yeah. So the answer for this one is B. Any reasons why? Yeah. It's just a pretty typical picture for presbycusis. So you lose the hearing bilaterally at sort of the higher frequencies, which the sort of the reverse Nike tick, that would be more of a noise induced hearing loss where you get loss at one particular kind of frequency. Obstructive hearing loss, you'd kind of expect it across all frequencies, and it would be different between ears depending on what's blocked. And that's likewise with acoustic neuroma, it won't be both ears affected. Another very classic GP ENT presentation where we need to make a decision on how best to manage. What are our thoughts? First of all, what condition is this? Yeah, he's got tonsillitis. So are we thinking bacterial? Are we thinking viral? How concerned are we? Yep, so I'm hearing Centaur score. And yeah, a Centaur score of 2. So that is correct. So that, yeah, the answer here is D, and that's because we need to apply the Centaur criteria. So he doesn't have a cough and he doesn't have a cough and he has the purulent tonsils, which are both features of bacterial tonsillitis, and that would give him a score of 2. However, he doesn't have any kind of real concerning factors for a risk of like group A strep, rheumatic heart fever. And so therefore we don't necessarily need to provide antibiotics straight away. The main thing is we do need to take a throat swab and then wait for results before initiating antibiotics. Any questions there? We're good? Yep. So I'm hearing a few whispers. What are we thinking? C. Yep, exactly. So the rest of them are all risk factors for OSA, but side sleeping would probably be protective. Any thoughts on why that is? Exactly. So sleeping on your side opens up the airway more, and so that would be protective. All right. Now, just the last 5 are on sort of men's health or genitourinary. Any thoughts on the management for this gentleman? Chat, we see the question. We will get back to you in a minute. All right. For this question, what are we thinking? Give me some answers. I feel like I'm hearing C. Yes. So C is your first line for BPH. Oh, hang on. Yes, C is our first line for BPH. For A, we don't really use 5-alpha reductase as monotherapy. Usually that's second line, and we're combining it with the alpha receptor antagonist. The PDE5 inhibitor is more for erectile dysfunction. And then antimuscarinic monotherapy, again, that's sort of looking really last line. And it's more to treat kind of overactive bladder or urge incontinence. And then, refer to urology for a TERP. I think at this point, we're not so concerned about that. It's more once pharmacological managements are sort of failing or if they have quite significant retention.
So there was a previous question just with the the tonsillitis as to whether you would consider EBV. Just with the lack of lymph nodes and a lack of temperature, it would be a bit less likely to be glandular fever. Maybe if later down the track that kind of rises up, then maybe you consider investigating that. But again, because glandular fever can be self-resolving as well, that can just be something that we observe and see how they go. But yeah, in this case, we're probably a bit more concerned about a bacterial cause of the tonsillitis. So we want to swab it based on Central criteria, see how that goes, and then consider antibiotics if they need it.
All right. Right, next question. This one has a few layers to it. I guess starting off, what do we think this patient has? Or what are we worried about? Yeah, I'm hearing gonorrhea. What else could it be? Yeah, chlamydia is the other one as well. In that case, what do we want to do for this patient? Yeah. So yeah, the answer for this one is B. So the purulent discharge is more associated with gonorrhea than chlamydia. You get more discharge with gonorrhea. At the same time, we can't fully like just tell them apart on clinical presentation alone. So we've done a swab, which is the right thing to do. And then the next step is just to immediately start gonorrhea management, which is the ceftriaxone and azithromycin, which will also cover chlamydia treatment. Does anyone know what you do to treat chlamydia? Yep, so that's doxycycline. And doxycycline is slightly more effective than azithromycin for chlamydia treatment. So if the swab came back then positive for chlamydia, we could change. But otherwise, we are still kind of covering it. We do still need to swab, however, because there's also resistance as a possibility too. So you need to get your sensitivities back. What are we thinking for this question? There's a bit of reading to get through. Anyone committing to an answer? D? D? Great. Yeah, so this one is D. It's kind of one where you just have to find what's wrong with every answer. So yeah, anal swabs, yes, that's important, but given his practices, will also need an oropharyngeal swab and first pass urine for A. For B, if he was on prophylaxis, then HIV prophylaxis, then he would need to be tested for HIV. And with the anal and urethral swabs, that's a serology when it comes to hepatitis, so that's not really relevant. D is correct according to their Australian sexual health and STI guidelines. And then with E, we would also need to do anal and oropharyngeal swabs. So another one that requires a bit of reading and thinking through. I think we have an A for from the chat. Any thoughts on any other answers? So does anyone know what this is? Yes, HSV. And what makes you think it's HSV? Yeah. Yeah, so it's more of a vesicular type of lesion. Yeah, I didn't really know that very well either. So But yeah, so the answer for this one is B. So for HSV, they can recur, especially if they're immunocompromised despite treatment. So it's something you just have to warn the patient about. For answer B, that's what you would do for syphilis. And if you remember any buzzwords about those ulcers, they're generally painless. So that also won't be the only investigations you order. You'll also need to swab the wound and send it for a PCR. For answer C, HSV is not a notifiable disease, so we don't need to worry about that. And the test of cure is not, again, something we need to do in this case as well. The answer D, that's for HPV, not HSV. And those warts, although painful, won't be vesicular. All right, last question from general practice. Any thoughts? What do we think is going on with this patient? Yep, I'm hearing whispers of rhabdo. Yeah, so what are we going to do then in that case? I don't know, I think. Yeah. Yeah, so for this one, it's E. We would just repeat the urine dipstick in the early morning specimen because this sounds like it's exercise induced given the marathon yesterday. So yeah, we would just have to see that it's resolving, nothing else in this case. So that is all from us at GPSN. If you felt like those questions revealed some gaps in your knowledge, we have some revision lectures on all these topics, as well as some great resources on our drive. So be sure to check those out. And then just the MIPS MCQ, sorry, not the MIPS MCQ, the MIPS prize draw as well.
Just with the MIPS giveaway as well, the announcer will be announced. The winner will be announced tomorrow. So we'll send you through an email if you win. That's just to keep an eye out for that. Yeah. But good luck.
All right, everyone, let's get started. So my name's Yuri. I'm from the SciSom academic team. I'm joined by Nasuli and Kavya, who'll be going through some psych questions with you today. Thanks for bearing with us for what has been a very long day for you guys. So let's head straight into it, shall we, with some MSc questions. Is that? So what are people thinking at this moment? Hearing some A's. Yeah, so this is ideas of reference. Mental state phenomena are a pretty big, significant portion of the psych exam. So this kind of question is something you'll see a lot. So ideas of reference is when somebody attributes like a strong personal significance to something that is in their environment. And next MSc question. Oh, and if you guys have any questions throughout, just feel free to shout out as well. Okay. So for this one, the answer is B, circumstantiality. So it's a type of, like, it's a way to describe thought form. It's not necessarily pathological. It's because it's always coming back to the original point of the conversation. Yeah. And the difference between A, B, and C is pretty important to know as well. Next question. Anybody have any ideas? Hearing like A, maybe I'm also hallucinating and hearing stuff. But the answer for this one is delusional mood. Okay? You guys might not have heard of this before, but basically it's this like impending feeling that something in your environment is about to change, or that something is just like vaguely off or wrong about the world. And often it's a precursor to development of psychosis as part of the prodromal phase. I heard some people say A, so like autochthonous delusion you might see in some past papers. It's basically when somebody forms a fully developed complex delusion overnight or very suddenly. So it's almost like the opposite of delusional mood. So there's just some things that you have to watch out for, like the different kinds of delusions. So there could be so many ways to describe mental state. Okay. Next question. See. Yep. So there's somebody said PTSD in the chat, and I heard it in the room as well. So the diagnosis for this lady is PTSD. There's been a traumatic event. She's experiencing all the symptoms that meet the criteria for PTSD, like re-experiencing the event, avoiding triggers at the event. And the other thing that's also always important in a psych STEM is to look at the time frame, because they can really trip you up, especially with all the different kinds of psychotic disorders. And that's where you have to be familiar with the DSM criteria for some of the R ones. Yep.
PTSD explained that you wouldn't choose agoraphobia.
Yeah, because she's experiencing nightmares, reliving the traumatic event. Yeah. Agoraphobia doesn't necessarily have a traumatic event after which the patient starts to develop symptoms. It fits better under the criteria of anxiety disorders, which don't necessarily develop due to one singular event. Does that make sense? Yeah. Yep. Yep.
If what she's fearing is only related to like the train setting and those,
Yep.
then it's more inconsistent with PTSD. But what if she also had fears of like, I don't know, lining up for like at a restaurant or something, or other like social or public events that are not
Yep.
in line with that traumatic event?
Yep.
Could there be like two separate, could it like also be agoraphobia?
So this could be agoraphobia if she experienced other sort of social anxiety symptoms, or like fearing public crowded places. Is that kind of what you mean?
Unrelated to like the train.
Right. If that's unrelated, then you could consider a dual diagnosis of agoraphobia and PTSD. But also you have to think about to what extent those kinds of social anxiety symptoms are also part of her trying to avoid triggers of the event or reminders of the event. Next question. What are people's thoughts at this point? Anybody have any ideas? D, did you say? Okay. Yep. What? Sorry? Depression. Yep. That's right. So depression, there's some things that, some clues in the stem that point to this being geriatric depression rather than a neurodegenerative disease. So depression in old people can look like dementia quite often, but she has had this event, her husband passing away 8 months ago, which is a clear precipitating factor. Psychomotor retardation is also more suggestive of like the motor changes of depression rather than like, for example, Parkinson's. And short-term memory, including household tasks, recall, those are things to do with concentration, which can be affected by depression as well. So well done, everyone. I'll just double check if there's any questions. Well, you guys didn't see that. What do we think? Yep. So the answer is C, psychothymic disorder or psychothymia. This is where you have to be really familiar with the DSM criteria for depression, bipolar disorder, and all the psychotic disorders. So the way I would recommend that you approach it is to look at the time frame, 3 years. Mood swings only last a few days each. She's obviously having, hypomanic symptoms, depressive symptoms, but they don't meet the full criteria for a full-blown manic episode or a hypomanic episode. And you have to assess the level of functioning. So she doesn't actually, these mood swings don't affect her level of functioning. Not likely to be an organic cause. So since she doesn't meet the criteria for A or B, it's C. Yep, this one. C. Somebody said C. Yep, that's correct. So the answer is lithium. So all four of these options are mood stabilizers. There's a few clues in the stem. I mean, technically you can say he was only recently diagnosed with bipolar, and so lithium is the first line treatment for that. But also the coarse tremor, nausea, diarrhea, they are all early signs of lithium toxicity. Because lithium has such a small therapeutic window, it has to be titrated very carefully. And because lithium is renally cleared, things that can cause dehydration. So he's working on a 40-degree day outside. Dehydration can exacerbate or precede the onset of lithium toxicity. And the coarse tremor especially is a sign that it's more pointed to C than the other options. All right. This is a bit of a tricky one. What do people think? I'm hearing schizophrenia. I'm hearing C. C? Okay, let's see. Obsessive compulsive disorder, option C is correct. So yeah, as I said, this is a bit of a tricky one. There were some curveballs like throwing in 6 months for that schizophrenia time frame and not in line with the beliefs of the family or the church. But this is what's called like morally scrupulous OCD with religious themes. So there's clearly an obsession, which is an unwanted thought, okay? The defining characteristic of obsession is that they are ego dystonic, okay? It distresses the individual to have these kinds of thoughts. And there is an action or something that they do in order to cope with these thoughts or get rid of those intrusive symptoms, and that's prayer in this case. So there's clearly an obsessive component and a compulsion that's associated with it. And that's more in line with OCD. I'll just double check if there's any questions in the chat. Yep. There was one, but we'll get to it in a second. Okay, what drug is responsible in your guys' opinion? Yep. So the answer is clozapine. So this person has had 2 treatments with 2 different antipsychotics with little therapeutic effect. So the next line would be clozapine. Weight gain and excess salivation is very, very typical or has high risk with clozapine as opposed to other antipsychotics. Aripiprazole doesn't have as big of a weight gain side effect. Neither does quetiapine and risperidone. You get that excess salivation and neutropenia, which more likely suggests clozapine. I also put, she cut down her smoking during this time. Smoking is really significant to think about in patients with psychosis because it can affect the serum levels of clozapine. And it's really important to flag to the patient to let you know if they change their smoking habits. And cutting down her smoking would have increased her serum concentration of clozapine and caused these side effects. What do people think? A? That's correct. So the answer is A, schizophreniform disorder. So he has all the hallmark signs of some kind of psychotic disorder. He might be responding to internal stimuli. He has these negative symptoms like isolating himself, withdrawing from usual activities. The key here is 3 months. So they really like to trip you up in the exam with the different time frames that are associated with like A, C, and D. So D is 1 month. Brief psychotic disorder is 1 month, Schizophreniform is 1 to 6 months. Schizophrenia is at least 6 months. Schizoaffective disorder has to have a mood component in his presentation, which this boy does not have. So I'll just go through some questions that were in the chat. So I think for one of the other ladies, the psychothymia lady, they were just asking, where is it? Why doesn't it meet the criteria for a hypomanic disorder? Well, it doesn't affect her functioning. Still able to socialize and fulfill job requirements is the key component. So like bipolar 1 is you need to be hospitalized basically for it. Bipolar 2 has to affect your functioning. So that's that, although she does have hypomanic symptoms. And with the depressive episodes, she has symptoms of depression, but she doesn't meet the full criteria for a depressive episode either. Ego dystonic based on STEM for question 8. Yep, so he's afraid, how is this ego dystonic? So it's plaguing him. And it's afraid that he may harm others if he doesn't pray. So he doesn't want to be having these unholy thoughts. So that's how it's ego dystonic. And what is it, I assume this is the same STEM, what is it about the presentation that contradicts schizophrenia? So he's religious. It's okay to be like, within the beliefs of the church or like beliefs of his ideology, things like praying and talking to yourself and things like that don't necessarily have to represent psychotic symptoms. He doesn't really have hallucinations or delusions in this STEM that would indicate psychotic symptoms either. It's more along religious themes. Were there any other questions? ACND? Or where was ACND? Huh? Oh, okay. Okay. I think we might leave it there. If there's any other questions, we can get to it. Thank you.
Hi everyone, I'm Nasuli. I'm going to be going through the next 10 questions. So this one is just about side effects. Any thoughts? Yep, so the answer for that one is A. So in particular, olanzapine and clozapine cause metabolic syndrome as a side effect, and some patients will be started on metformin to alongside the second-gen antipsychotics to deal with that. Yeah. Yeah, so the answer to that one is C. An insidious onset and along with the negative symptoms is more linked to poorer outcomes, whereas an acute onset and better pre-morbid functioning is associated with better prognosis. And in terms of the others, I think the risk in terms of between genders is quite similar, so that's not necessarily predictive of a worse prognosis. And yeah, I think that's for that one. This is an ED question. So the question's about mortality specifically, if that helps. Should I just... Yes, so the answer to that one is C. So the low BMI and the chronicity and the duration of the illness is, of course, important to determine prognosis, but acute mortality itself is more strongly linked to how bad the electrolyte disturbance is in this patient. And it's usually a result of purging and refeeding, but it's the electrolyte disturbance itself that determines or predicts mortality. Because it can increase the risk of arrhythmia and sudden death. It's another ED question. Yep, so the answer to that one is family-based therapy. So in eating disorders, if the patient is medically stable, which Emily is, and she's motivated and her parents are motivated and she lives at home, so the best option for her is family-based therapy. In terms of the other options, if she wasn't medically stable, admission to the inpatient ward would be indicated, and then dialectical behavioral therapy is for borderline personality disorders, and CBT is for mood and mood disorders mainly. Yep, so someone in the chat has said B, which is the correct answer. So I guess the ones that people were probably tossing up between was A and B, but I guess what differentiates something from being normal versus being pathological is whether their functioning is impaired. So you can see here that the mum isn't interested in the baby's activities and she hasn't left the house, and she's not looking after herself or the baby, which points more towards postpartum depression than baby blues. Baby blues should also subside within the first 2-ish weeks after giving birth, and now it's been 4 weeks for this patient. And in terms of the actual symptoms, so it should be at least 5 of the depressive symptoms in the same 2-week period, with one of the symptoms being low mood or loss of interest. But yeah, the anhedonia in this case is the main thing that differentiates this case from a normal postpartum adjustment. Yep, so the answer to that one is D. So personality changes, change in behaviors is what characterizes frontotemporal dementia. In terms of the other one, Alzheimer's usually involves very gradual memory loss without any acute neurological changes. And then Lewy body dementia and Parkinson's dementia is not quite the same. So Lewy body dementia is characterized by sleep disturbances and some visual hallucinations. And Parkinson's disease dementia is kind of a later stage of Parkinson's disease where they've already had some of the motor changes and the cognitive impairment happens a bit later on. Oh, yeah. Hi. Mm-hmm. Mm-hmm. Jason.
Yeah, so the question was, would this meet the criteria for postpartum depression and not better explained by adjustment disorder? So another really important aspect of postpartum depression, especially when you differentiate it from baby blues, is how it affects attachment to the baby. So here, she's not interested in a baby's activities. So while a lady with baby blues might say, oh, like, life sucks right now, but I love my little bub, that's not the same as postpartum depression. Adjustment disorder, whether it would meet the criteria, it would be better explained and would be the most likely diagnosis. I don't really think so. Because it's all surrounding her. It's like she's still in a postpartum stage, so this would fall under the field of perinatal psychiatry in her presentation, rather than adjustment disorders.
Yeah, I agree. I think like after birth, the patient is not just the mum, it's the baby as well, I guess. So whatever fits criteria best so that both of them have the best outcomes. So I think in that case, PPD is the better option, yeah. It's another dementia question.
Diagnosis. Like, there's a lot of it's like you have to make a diagnosis on like his second year. There's like two-step thinking.
Yeah, that was as well.
Sometimes I make the diagnosis at the end of.
Yeah, I know you read the whole step and it's like for nothing. No.
Any thoughts with this one? B, did someone say B? Yes. Yes, so I think the MMSE score in this one is probably what tripped you up. So 25 and over is usually what's considered normal. But for a patient who's non-English speaking background and like you can't expect them to have exactly the same because a lot of the questions do require English proficiency. And the other aspect of this that points more towards normal aging than dementia is the fact that she's not forgetting anything that's particularly important, and she's still able to function independently at home. So she's only forgetting like the names of people and certain things she has to buy at the shops. She's not forgetting to like turn off the stove. And yeah, and the other aspect is, so she's dropped out of high school, so the lower education background as well. So all of those things need to be taken into consideration when you look at the MMSE score.
I'll try to keep mine. Mine was quite. Depends. Yeah, I think I did this.
Yep, so someone has said A, which is correct. And I heard someone say stepwise, and that's exactly right. So there's been two events, so the cerebrovascular event and a second for neurological changes, which might have been another stroke or something. And yeah, the stepwise decline characterizes vascular dementia. And his medications that he's on, that kind of points towards a CVS picture as well, the ramipril and the propranolol and the statin. And like we already talked about, the frontal temporal dementia causes personality changes and behavioral changes. Lewy body dementia is linked to sleep disturbances and visual hallucinations, and then Alzheimer's is a lot more gradual in its progression, so it's not quite that one. Yep, so A is the right answer for that one. Any thoughts with this one?
Yeah.
Yeah, no, sometimes it does that.
Yeah.
The screen will flicker in a bit, but it'll come back.
Okay. Okay, so I think we've got some D, some A, and I think that's the options that it kind of comes down to. You probably ruled out aripiprazole and clozapine because they are typically used in more of the long-term management of psychotic disorders, and clozapine specifically is used very later on. So the options that are left over are haloperidol and diazepam. And for delirium in the elderly, generally haloperidol is used, or risperidone or olanzapine, just because diazepam is hepatotoxic, and this patient in particular he has cancer of the liver, so the diazepam is contraindicated. But diazepam is like generally used as a muscle relaxant in a lot of patients. And diazepam, yes, it has other indications as well, but in this particular case, it's only contraindicated because of his liver disease. Sorry, can't hear you. Oh, sorry. Yeah, so the question is whether the diazepam is contraindicated in this patient or in all patients, right? I think I would say that haloperidol, risperidone, and olanzapine are generally first line, but diazepam I think is used.
I think one thing to note with aged psych is that benzodiazepines in general can cause or be a precipitant for delirium. So people also tend to avoid them in the elderly population because it can make them even more agitated, like kind of have like a paradoxical effect. So if they're over like 65, I would probably stray away from diazepam or other benzos.
You guys say that. But also.
Yeah, so there was a question in the chat that was saying, isn't haloperidol used quite sparingly because of the potential extrapital side effect profile? Yes, you are right, depending on the medical background as well. So could you go back to the questions then? So, so that's why more than haloperidol, just from personally what I've seen, like haloperidol is sometimes used, but also olanzapine and risperidone are there side effects as well. But you have to, the thing about, and this kind of goes into haloperidol versus diazepam, but what you're trying to treat is the agitation. So diazepam or like benzos are an anxiolytic. Haloperidol, risperidone, olanzapine, the good thing about them is that they are sedative and they can actually treat the problem, which is agitation in this patient. And usually like in this kind of setting, they are administered as like fast-acting medications formulations, so it will be out of the system quicker than usual.
Yeah, and I think this case, because it's a terminal cancer, it's a palliative patient, so dealing with the immediate problem is kind of important as well, like not regardless of the side effect, but more important than the side effect, I think, in this specific scenario. I already showed the answer for this one, but so we have a D in the chat. Yeah, that is the correct answer. So SSRIs are generally considered very safe in pregnancy and in breastfeeding as well. And the main thing that's important is that for a patient that's had long-standing anxiety disorder, that she's mentally well during the pregnancy. Fluoxetine is safe as well, but it is not recommended during breastfeeding, so it might be better for her to start something that she can continue on to after the baby's born, so that she's not having to deal with a new medication after the pregnancy.
Hi everyone, I'm gonna go through the next 10 questions. This is a fun drug one again.
The liver clearance.
Yeah.
She? I just.
So we have someone in the chat say, does anyone want to yell out an answer? Yeah. So I think the acronym that people use is like OTL, outside the liver. So oxazepam, temazepam, lorazepam, they are like metabolized. You can think of them as metabolized outside. Yes, LOT, alcoholics drink a lot. Sure.
Yeah.
Whatever helps you guys remember, I suppose. Yeah. Yeah, that's not much more to this question, so I think I'll move on. So this one is mirtazapine. It's not highlighted there, but it's B. So this is the best option. So we want to avoid the SSRIs and SNRIs because of the history of the hyponatremia on sertraline. And then mirtazapine also helpfully, as a side effect, causes weight gain, which you might want to avoid in some populations. But in this one, since they've lost weight, it can be helpful. The Mayo inhibitor is an option, but it's usually not first line. So I think mirtazapine is the best option here. Next question. Does anyone want to yell out an answer? Okay, so this one is serotonin syndrome. So the mnemonic is the shivers. So shivering, hyperreflexia, increased temperature, vitals unstable, encephalopathy, restlessness, and sweating. And then I guess you can rule out the other one. So akathisia is like the restlessness and like pacing and stuff, but all the other signs like the clonus, hyperreflexia, wouldn't be present. And then this isn't like a neuroleptic malignant syndrome, which usually is hyporeflexia, and it usually progresses over lots of like a longer time, like days, and more to do with the dopamine pathway and antagonist, not really by the serotonin pathway. And as the symptoms sort of started as soon as they, like 6 hours before they started sertraline, yeah, you can be pretty confident that this one is serotonin syndrome. Anyone have any thoughts? C? C is correct. So it's good for reducing cravings and withdrawals, and it's got a really low risk of sedation and respiratory depression. So yeah, it would be probably the most appropriate. Methadone is an option, but I think it has that higher risk of those like sedation and respiratory depression. Continuing on with the drug questions. All right, we had someone in the chat say D, which is correct. So this is a Wernicke's encephalopathy. You'll have your decreased thiamine in people with the chronic alcohol use, and it's like the, I guess, pathognomonic triad of cognitive issues, ataxia, gait disturbances, and then the oculomotor dysfunction. You would treat that with some thiamine supplementation. It is a reversible disorder, so it can resolve after the thiamine, in contrast to Korsakoff syndrome, which is irreversible. And so that's why you need to treat Wernicke's like as soon as you see it, because if you don't, you can progress into the irreversible Korsakoff. The only other option here that would maybe trip you up would be diazepam, but that's for alcohol withdrawal. And so you'd have to be abstinent for a period of time before it would be the appropriate option. Anyone have any questions? Okay, I'm hearing lots of different answers. I heard someone say C, which is correct. So this particular question is asking for someone who is having cravings and they have already been abstinent. So in that case, acamprosate, I don't know how I'm supposed to say it, but that would be the best option. Disulfiram is also used to help people with alcohol use disorder, but it causes that really like extreme unpleasant reaction to drinking alcohol. So it's good for people who are trying to quit, but they haven't been able to and are still drinking. Whereas acamprosate is better for when they've stopped and they're having really bad cravings. Yeah, the other two options are for like different substance use disorders. Yeah.
Just a random side tangent since we're running ahead of time. But if you get Asian flush, that's what disulfiram does, because like the way the disulfiram works is that it inhibits aldehyde dehydrogenase, which is exactly what happens in Asian flush. So if you get Asian flush, you guys like really should not be drinking at all. Just my little PSA.
Stop drinking.
Yeah.
Primary care, primary prevention. I didn't know that. This is like natural disulfiram.
Yeah, it's like form of
But do you get all the gross like headaches and the vomiting? Oh, yeah. You get like the vomiting and the headache and all that bad stuff. Yeah. 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 I have a friend who's like that, and we thought she was allergic to alcohol.
It basically is.
Say that. Yeah. How sad. That's really. I don't know if I could do. Any thoughts here?
Yeah. Why don't you use naltrexone?
Good question.
It's also, it's used the first line, I've seen like it's easy dose.
Do you know? The question, we had a question about the last slide. Oh my God. How do I go back?
Yeah, you said.
Ooh.
What was the question?
Why not now?
So the question is why acamprosate and not naltrexone? So acamprosate and naltrexone both reduce cravings, but they're more effective in different scenarios. So acamprosate is better for reducing cravings for the aim of like complete abstinence from alcohol, whereas naltrexone is more effective when you're still drinking alcohol, but you want to reduce craving, like drink less and for harm reduction purposes. So different contexts. Yeah. So when somebody's first expressing wanting to reduce their alcohol consumption, first line would be naltrexone.
So this one, I don't think I've had anyone say, I haven't heard anything. Oh, yep, great. So this is I guess the sister question to the one from earlier. The fact that he doesn't think his behavior is particularly problematic points more to the obsessive compulsive personality disorder as opposed to the obsessive compulsive disorder. So it's like ego syntonic as opposed to obsessive compulsive disorder, which is ego dystonic. Yeah.
Yeah. Yeah.
Anyone have any thoughts? This one is B. The physical symptoms that she's having with no like organic cause, bit of a, I guess, red flag. There's not really any like clear gain from doing this. And then having her 5th presentation to 3 different hospitals it's kind of like doctor shopping and wanting really invasive investigations, but for no I guess gain or outcome, is indicating factitious disorder. Does that make sense to everyone? So, I mean, I guess I'll just explain the difference between the other options. Malingering is like when you want that, you're trying to gain something. So in this situation, she's not like trying to scam NDIS or something. Like she has no gain. And then with functional neurological disorder, it's usually it's unconscious. They don't know, they're not doing it on purpose. And then somatic symptom disorder, actually, yeah.
Yeah, just to go through the options just a little bit in more detail, because it sounds like there's a lot of discussion about this stem. So yeah, it's fictitious disorder, which was previously known as Munchausen syndrome, i.e. the Gypsy Rose thing was Munchausen's by proxy. So you have to assess, is there a secondary gain or not? Secondary gain can be things like, financial reasons like NDIS, getting out of work, something like that. There's not a secondary gain here. The gain, like the primary gain, so to speak, is the patient role or the sick role that this lady is trying to gain. And that's like the characterizing fact of like core component of fictitious disorder. Other ways you can differentiate it. FND, you get neurological symptoms, so you can elicit them, but as Kavi already said, they're not conscious. And also another way that you can try to glean FND versus fictitious is they will be, people with FND will be looking to resolve their problems and be reassured by investigations. Whereas with fictitious disorder, they are not satisfied with investigations or when there is like, they don't react well to reassurance. So like, for example, in this stem, like she refuses to leave without an MRI. That's something that you can see quite a lot. With somatic symptom disorder, it's more of a, like, there's a stronger psychological component to it. So, for example, a traumatic event like a psychological trigger that is manifesting in physiological symptoms. So they are presenting with psychological symptoms in a physical way. So that's more what somatic symptom disorder is. Like, for example, person with anxiety who gets headaches.
Thanks. So I've seen some questions in the chat. I think we might go back to them at the end. There's only 2 more questions left.
Yeah. Ignore that one.
They told me they'll never ask about Crefts.
Yeah. Dude, I'm getting across.
All right. Any wanna have a go? B? Yep. So the answer is B. So I think it can be clear like that you need to do something. Like you can't really just send them home and safety net that way because they're like I guess feeling very hopeless and alone, and has a history of self-harm. So then you want to decide what you want to do, and advising the patient to present to the ED is something that GPs can do often, but the best thing to do would be to refer the patient to the CAT team. They're like a specialized ED team specifically for people in crisis. Whereas if you send someone to the ED, there might be a lot of delay in them getting seen, and you don't really want to be risking that time delay when someone is having an imminent crisis. And then referring them to a different therapist, I think you would just do maybe like a bit later or have the CAT team have input until her regular therapist comes back from holiday. So yeah, it's B. Last one. Okay, I'm hearing lots of C's. The correct answer is C. So this would be a really good thing to really know for the exam. There's always questions on it. The pathway of like getting someone from, I guess, like the pathway of placing someone under an assessment order, and then what happens if they need further, if they need treatment after. So when an assessment order allows the psychiatrist to make an assessment, but it doesn't really give them the ability to give involuntary treatment. So if you want to help someone with further inpatient care, you need to put them on a temporary treatment order. And then after the temporary treatment order is in place, and you want to continue beyond the 28 days, you put them on like either an inpatient or a community or whatever is treatment order, whatever it would be appropriate for your particular patient. Yeah. Any questions? Cool. Let's check the chat. Someone said in the chat about the FND question, from experience, a lot of people with FND are not easily reassured, and that is very, very true. I think a lot of the exam questions are just sort of like learn the buzzword and learn the pathway.
Yeah, just like general tips for the exam as well. I mean, we try to write these questions in like the same kind of style that we had our exam questions. And especially just want to make a note about like the R3s, which are mostly personality disorders. They're all very spot diagnosis kinds of questions. And it's very, for the lack of a better word, it's very vibes based. So they're not really trying to trip you up with the R3 personality disorder questions, except for BPD, which is, they write in a pretty stereotypical way most of the time anyway. Yeah, so just know the various mental state phenomena, like know the differences between them, know psychotic disorders, depression, bipolar pretty well, and the side effect profiles of different medication classes. That's just what I would think is the most high yield. All right. That is the end of our 30 questions. Any last minute question? Oh, thank you. Benzo, oh yeah, there was one last question. So can you please clarify the benzo and liver impairment relationship you were explaining earlier? So benzos are hepatotoxic except for OTL, oxaz, tamaz, and loraz. I think that pretty much it. Any other last minute questions for psych? No? Okay. So good luck, everyone. We're sure you'll smash it. Just a quick slice on plug to all our academic resources, our past papers, lectures. We got summary packages. We got Apex History Plus practice for you guys. And also we've written a new practice paper this year, and that will be released very soon. So look forward to that. Thank you so much, guys.